plenary session forum. And for our first talk on the plenary session, I would like to invite Dr. Gundu H.R. Rao from University of Minnesota, USA. Please welcome him.
Good morning, everybody. It is indeed a great pleasure for me to visit Hyderabad, which I have visited many a times. Every time it is a rewarding experience for me. I thank the organizers for inviting me to share some of my views this morning. My major area of interest is prevention of cardiometabolic diseases, hypertension, obesity, type 2 diabetes, heart disease, and stroke. I worked on a single cell platelets for the last 40 years. I'm the director of thrombosis research in the famous Lilla Heart Institute in Minnesota. Now, currently I'm retired, but I spent 6 of 12 months in Bangalore working on a number of collaborative projects. In view of my interest in cardiometabolic diseases, I will try to begin my lecture this morning by informing you how we got involved with the traditional medicine. I've been organizing conference through my professional society, which is one of the co-sponsors of this meeting, South Asian Society on Atherosclerosis and Thrombosis. I was invited by Government of India in 1990 to help develop thrombosis research here. Visited hospitals from Kashmir to Trivandrum 3 times in a row, 1991, 92. I found out that Indians by and large, and also Pakistanis, Bangladeshis, Sri Lankans, as a group, have a very high incidence of heart disease and type 2 diabetes. In view of this observation, I started this professional society to conduct conferences in India, develop educational and preventive programs. Since 1990, we have organized about 20 conferences in India, have published 5 books on the subject in India. And the book on diabetes was bought by GSK, 10,000 copies. It has been distributed to clinicians in this country. Having done this type of educational work in India for over 2 decades, we decided that it is high time that we should take this message to the level of the community and also see how we can develop an affordable health care. You are very well aware that in a country like India, probably 20% get the allopathy. The rest of the country, at the level of rural, there is no real health care at all. They are left to whatever it is that they can reach out. And even within the 20% of the people that I consider the elite and who get the modern medicine, if you visit an average family, one person goes to Ayurveda, another goes to homeopathy, third one looks at Siddha. So not everybody goes to one particular type of therapy. Since we don't have a paid insurance system, people who pay would like to go whoever they feel comfortable. Yet, we are not being able to standardize all of these therapies. Although we have Ayush platform for 2 decades or 3 decades, they still have not coped up with the advantages and taken serious interest in standardizing these practices, though so that they become globally competitive. In 2006, during our SASET conference in Bangalore, we discussed how we can develop an affordable health care for all of people in India. The experts who met that meeting thought that just taking the modern medicine may not help, because if I found out somebody is diabetic at the rural level, and tell them that they have to take metformin. First of all, it is expensive. Secondly, they may say that we don't believe in this modern medicine. We would like to maybe eat Karela or have fenugreek or whatever. Therefore, we have to come up with a novel, out-of-the-box approach to develop a platform for this country where we can bring all of the other therapeutic methodologies we have, which we put under traditional medicine, onto the same platform. With that idea in mind, we developed two professional societies. Both of them are sponsors of this conference: Global Alliance for Traditional Health System and Mind, Body, Spirit Society of India. You may wonder why too. I'll tell you why. University of Minnesota is probably one of the only institutions that I know where a full division exists on spirituality and health. None of the medical colleges in India even have a course in spirituality and health, because we think we're all spiritual. But how do you use this spiritual knowledge towards health is totally a different thing. So in view of that observation, I thought that we should also remind that although we are all spiritual, there are ways we can help the population in bringing this into the healthcare platform. So with these two professional societies, I thought I will take the traditional medicine of India to the global platform, try to organize a conference in Oregon with the Integrative Medicine Group of USA. However, it didn't happen because Ayush was not very proactive and didn't come up with any supportive ideas. However, I have presented what I'm going to tell today in the 4th Ayurveda conference in Bangalore and in the 5th Ayurveda conference in Bhopal, and I will share some of these perspectives with you so that you understand how we think about integrative medicine and how the West thinks about integrative medicine, what they have observed and what they are not willing to take. In recognition of the growing body of evidence, in February of 2009, the Institute of Medicine of National Institute of Health USA organized a summit on integrative medicine and health of public. More than 6,000 health partners, scientists, policymakers, academic leaders, and patient advocates came together to share their views. The summary of the summit states that this disease-driven approach to care has resulted in spiraling costs as well as fragmented health system that is reactive and episodic as well as inefficient and impersonal. It's a very true statement, because nobody has any time for me when I approach the physician there. And secondly, modern medicine has failed in terms of prevention. It only treats the disease. According to the Institute of Medicine, the first priority for any healthcare system using an integrative approach is to ensure that the full spectrum of preventive opportunities, clinical, behavioral, social, spiritual, and environmental, are included in the care and delivery of the system. In the opening remarks, the President Harvey Fimberg explained that integrative medicine encompasses the whole spectrum of healthcare interventions, from early diagnosis to prevention, treatment, rehabilitation, and recovery. Just want to mention here, in India, when we are talking about priorities, we don't even know what our priorities are. I'll tell you a fact. 30% of the children born even today in India are of low birth weight. And this seminal study is done in Mysore for last 65 years. Mission Hospital, Mysore has records from 1936 on every child born. And they have followed these cohorts low birth weight cohorts for over 6 decades and found that these children are highly susceptible to cardiometabolic disorders. I'll tell you why. When the child is growing, the primary purpose there is to survival. And because of that, they conserve fat. Genetically, they are programmed to conserve fat as a source of energy. So these children who have intrauterine problems in growth are born with low weight, but they are thin, fat babies. They have a lot more fat per area than the normal baby. And because of this genetic program, it continues throughout their life, the accumulation of fat and altered fat and carbohydrate metabolism. So what I'm trying to say is this disease that we are talking about, chronic cardiometabolic diseases, starts right from the beginning and continues. In Delhi schools, 39% of the children are obese. And it's because of the habits that we have developed, the eating high energy, high fat foods and no physical activity, etc. Coming back to the thing that I'm talking about, National Center for Complementary and Alternative Medicine, NCAM, was established in 1991 as Office of Alternative Medicine, which was re-established as NCAM in October of 1998. So this is a part of the National Institute of Health and spends almost $200 million to promote alternative medicine. This institute offers many educational opportunities, funds for research, education, and conferences, encourages national and international collaboration. However, we have failed to integrate our programs with them or take advantage of this program. In spite of my efforts for 4 years, both at Karnataka State, Ayush, as well as at New Delhi, I have not been able to move them to address this issue. Over 50 US academic institutions have these CAM programs, what is this, complementary and alternative medicine programs, funded by the National Institute. By and large, these programs that are funded and explored at various educational research institutes are somehow related to pain management. Therapeutic aspects of traditional medicine in which herbal products or herbal preparations are used have no place in this system, as both the European Union and US FDA have banned the sales of these products for therapeutic purposes in their respective countries. I'm sure you will be discussing this towards the end of this conference. Dr. Edzard Ernst, professor of alternative medicine at the Peninsula Medical School at Southwest England, wrote in The Economist of May 2011, alternative medicine, think yourself better. Alternative medical treatments are rarely work, but the placebo effect they induce sometimes does. There is no alternative medicine. Virtually all alternate medicine is bunk. This is what he wrote in The Economist. We, the staff of the Global Alliance of Traditional Health Systems, were the only group to write a rebuttal to these articles. We also discussed these issues during the National Conference on Challenges and Opportunities in Traditional Medicine in 2011. I already talked to you about how we started these two professional societies. Coming back to the idea that I said, the Center of Spirituality and Healing at the University of Minnesota has developed extensive courses on the benefits of spiritual healing. In spite of the fact we are in India, consider ourselves as highly spiritual, we do not offer any such courses in our medical schools, not even in our traditional medical schools. Esther Sternberg of the National Institute of Mental Health USA in the IMM conference described the biological ways how bodies respond to both mental and emotional influences. Any sensor will initiate a cascade of neuroendocrine activity, and the neurotransmitters and hormones triggered by the brain regulate the immune response at cellular and molecular levels throughout the body. That is how mind-body system works. Cardiologists have realized that placing a stent in clogged arteries will not wipe out the heart disease. as it is not addressing the cause of the disease. The illness of loneliness, depression, anger, day-to-day stress, and hostility can be devastating to a person's health. We need to develop effective rehabilitation programs for post-MI and stroke patients using holistic approaches. Indians have a high incidence of metabolic diseases such as obesity, hypertension, type 2 diabetes, ischemic heart disease, and stroke. Both the Western medicine and traditional medicine accept that the digestive system is controlled by the mind, and anxiety and depression and fear affect its functioning. We should develop holistic preventive strategies as well as action plans for the prevention of these diseases. Ayurveda Goes Mainstream was the title of an article in the recent issue of India Abroad in USA, summarizing the proceeding of the 4th National Conference of Medicinal Plants and Herbal Products at Maryland, USA. WHO estimates that herbal medicines are still the mainstay of significant number of people around the world. Ambassador Nirupam Rao of India expressed confidence that the conference will provide a unique platform to share information and to foster research and development promotion of safe and effective use of medicinal and herbal products. According to various published sources, the market for Ayurveda products alone is about $1.5 billion. However, Professor Krishna Banadua, an expert of complementary and alternative medicine at George Washington University, said that the use of this traditional knowledge of healing in the USA has remained restricted. He also pointed out that severe lack in validating this science with the rigors of clinical research and support has hampered its promotion in the Western countries. He hailed the recent announcement by the Ayush to make clinical trials mandatory for all existing and new Ayurvedic medicinal products in India. Here I want to state that it is not impossible to do studies, scientific studies. In Sri Ramachandra Medical College, Chennai, Tanikok and his groups have studied a Siddha medicine for diabetes with 8,000 people, randomized study comparing it with metformin, and have shown that it has no toxic component, it is safe and effective. Only 3 things we had to prove: the toxicity, patient safety, efficacy. That's all is needed. The rest is all standardized studies. It's also true that AVP institution in Coimbatore has compared their studies on Ayurvedic medicine for rheumatic arthritis along with the studies from orthopedic departments. It is an NIH-funded study which has clearly demonstrated the beneficial nature of the Ayurvedic applications. They also have shown the mechanism by which it prevents the inflammatory pathway. So, we, the members of Global Alliance of Traditional Health System, welcome the Ayush mandate and do everything possible to support its implementation. And Professor Krishna also hoped that such conferences would provide US-India partnership opportunities, and Indian companies would benefit from collaborative work with the technical and scientific laboratories in the USA. So, our suggestion is we should establish an exchange program with NIH for our Ayush graduates to learn the science and art of how to conduct clinical studies. We should also establish an exchange program with all the major US universities which have complementary alternative medicine programs so that our Ayush graduates can learn how to conduct research studies in the healing art. In conclusion, there is no way we can provide the modern medicine to one and all in a country like India. Moreover, not everyone prefers the modern medicine as their primary choice for therapy. According to views expressed at global health care platforms, modern medicine has failed to prevent chronic metabolic diseases. The global healthcare platforms have been seeking complementary and alternative medicine practices to develop holistic approaches to combat chronic metabolic disorders such as obesity, hypertension, type 2 diabetes, heart disease, and stroke. I, as the founder of CEO, SACET, GOTS, and MBSSI, am organizing an international roundtable conference on development of translational science facilities in India to address these issues. You're all welcome to join us, and thank you all for your patience. We'll be announcing shortly. Any other comments or questions on what I presented? Since I also am a part of the chair, I will take it upon me.
Nice presentation, Dr. Gundu Rao, and actually, as far as you have expressed your view regarding the practical application of spirituality in the courses of traditional system of medicine, so I want to inform you that these aspects are already part of the syllabus, like prana is in Ayurveda, practical applications of prana in terms of therapeutics. Concept of Ruhr is there in Unani system of medicine, and even mechanism of drugs related to spiritual modification or Ruhr modifications, these are there. But unluckily, our graduates are have become materialistic, and they are not taking it into practical into their clinical practices. They don't know what are the spiritual modification done by this drug or this formulation or this therapy. So it's already there in the syllabus, but only we have to do the practical application. We have to improve. That's the thing.
I totally agree with you that in a traditional system that was developed over thousands of years, just about everything is there. But it is important for us to understand these principles and also promote these principles and develop appropriate curriculum to understand these principles. For example, I have heard several people saying that music has a role or meditation has a role. In this present situation, we can just about everything, we can analyze just about everything that is happening in the body in terms of chemistry and pharmacology. Okay? It's not that we don't have the technology available or the knowledge available, but we have not made any attempt, but we will just say that somehow it is doing. So what I'm trying to say is, if I explain a person how aspirin works, it is not important for him or her. But to me, it gives a confidence that I know all about it. When we are treating the patients, we should know how it works, what are the implications, what are the side effects, all of that. So when we are talking about holistic mission, it's not just the giving the medicine, but all other aspects along with it. And that's the traditional importance of the traditional medicine that differs from allopathy. In allopathy, you go with a chart which says what it is, and they give whatever it is. The rest is up to you. A traditional medicine, you spend enormous amount of time looking at all aspects of the patient. And that's what people like about it. I'll give you one example. In Medanta Hospital in Delhi, Naresh Trehan's hospital in Delhi, there is a surgeon from England, a young surgeon, and he does robotic surgery. Before the surgery, he has Dr. Geeta Krishnan, I guess, a yoga specialist. He treats every patient for 2 weeks, prepares them for the surgery. And after the surgery, again he treats them for 2 weeks, post-surgical, whatever the yoga thing. And I told them to publish this data. And when the patients are asked, everyone had one unanimous statement. They liked the yoga part better than the surgery. Why? Because the yoga part, the person has person-to-person communication for 2 weeks before and 2 weeks after, conditioning the mind and the body. Whereas the surgeon comes and does it, whatever it is, and goes. So that's, you can almost say, as a placebo, because you're conditioning the mind and the body to whatever is happening. And if even that placebo effect we can bring in, it's great, because it doesn't cost anything, there's no side effect. So in all of these aspects, we should look at this from the holistic purpose and not specifically take each one and say that this may not be necessary, that may not be necessary. Because here, the mind, body, spirit, diet, physical exercise, all of them play a role, especially when we are talking about prevention from day one. We cannot correct all of a sudden at the end of the story. Today you must have read in the newspapers the Srikanta Dutt, our heir apparent for Mysore throne, died of heart attack. And if you look at the details of it, he was a prime candidate for cardiac failure. He had overweight, increased body fluids, and he had a bypass surgery a few years ago. And even at that stage, it was preventable if the risk factors were taken into consideration and managed. So management is also important, just the therapy. So that's what I wanted to tell you. Anybody else has a?
Yeah, I think thank you very much for your very comprehensive presentation about the combining or integrating healthcare system in the Western world, like the USA and here. I did that, took that approach. In fact, National Institute of Health sent me to India in 1991 to examine that there was $150 million waiting only for India for research grant. So they asked me that why India not using. So they sent me, and I travel all over India, meeting with, of course, I did not meet with other except my nephrology, hypertension, internal medicine, you know, that type of it. And I asked them that why they are not doing research, why they are not writing research application. So NIH asked me that I can act as an interpreter for them, but I cannot write any application for them. There was not even one application received in the NIH after my travel. So what I'm saying, what is important, the doctors in India, including all professionals, Ayurvedic, allopathic, they must be more proactive in order to do something for their country and not try to integrate. I did develop through American College of Physicians, a group that they bring doctors from India or other part of the world to train them short term, but we ran into legal problem. That's one of the biggest problem you try to do in the US. We had to face the illegal part and how these doctors can be protected. So there are, what I'm saying, that the integration is a novel, but it is very difficult to accomplish. I met the Secretary of Finance Department of Government of India in New Delhi about the healthcare model tried to develop for India. They said, no, we cannot do it, that type of a model. So it's difficult. So the doctors here have to be more proactive to do research, to understand the problem, and then do the things.
It is difficult to influence the policymakers. I totally agree with you. But at the level of the institutions and the medical schools, agriculture schools, Ayurvedic schools, Unani schools, whatever the national laboratories level, we can definitely start initiating dialogue with the American universities as well as with the NIH and create appropriate exchange programs. Writing grants may be difficult, but creating exchange programs where faculty or students can go from here or bring them here is not a big thing. But we have to get that initiative from the institutions. And that will help, because students right now, even after postgraduate, are frustrated. They cannot go anywhere. In fact, I'll give you an example. One of the persons is doing his Ayurveda type of a therapy in Loni, and medical college will not allow this person to do his studies because he says it's not allopathy. Whatever he is doing is not allopathy, so he cannot do the study in medical. Where is he going to do the study? So we have to create a platform for integrative medicine where allopathy can be tested, Unani can be studied, Siddha can be studied, doesn't matter what. Any therapeutic protocol can be tested in a platform. That platform should be there in India. Sorry.
Yes, my name is Dr. Shashi Kansel from Bombay.
Yeah.
I'm a healer. So what you talk about one lady who's giving yoga and other things, the same way, I have also visited many people who are in coma. And I think one example like that only I would like to give you. that I was in Delhi, in Apollo Hospital. One girl was operated and she went into coma. And there was no relief to her. And doctor said, no, we can't do anything. Dr. Verma was there, Amitabh Verma. Then I went to, he invited me, he sent me, I went to Delhi, I gave her healing and I gave the acupressure point. And see, after 4 days, she was open up. And she was more active than before. Then Dr. Verma took me to his house, telling me that, doctor, I'm doing the same thing. I pray my God in the morning, then I go for the operation or anything. So you are right that it is working there. I got many people in the coma, they are still working and they are alive. Maybe many were gone, but many people are alive after my healing. That's all I would like to tell you.
It is important for us to recognize all of these modalities and document it and create a catalog of real therapeutic successes. I'll tell you one example. If you don't mind, I take a few minutes, just 5 minutes. The founder of Medtronics company in Minnesota, one of the largest companies in the world which makes pacemakers, went to Hawaii to settle down, R Baines. And even there, the local people asked him that he should develop a modern hospital for these people. These are Samoan Indians. And he said, why you want it? Americans have American hospital there. Why do you want another hospital? And these local Indians told that Americans go to hospital to die. We want to go to a hospital which is consumer friendly, which keeps us happy and alive. So he built a very unique hospital in the big island of Hawaii, North Memorial Hospital, where the Indian medicine man comes and can be an anesthetic. He will put them to sleep, they do operation without anesthesia. So I'm not saying that this is magic. So things are there, the mind control. It's not just the chemical. The chemical can be intuited by the medicine man, by whatever he does. So when we say music, it's the same. The music produces a certain hormones which causes bliss. In fact, this work was done in NIH under a Nobel laureate by an Indian student. The chemical that they synthesize which creates this blissful feeling is an amide, lipid amide. And this professor told him he wants a Sanskrit word for bliss. And this chemical is known as anandamide because it gives ananda. So what I'm saying is we can explain all the pharmacology and the chemistry, whether it is done by a medicine man or by a sage or a rishi, but we have to document these things, create an evidence-based document of all the therapeutic specialities. That's what I would like to see. As you said, you could reverse the process there. There are a number of people who have their own special therapeutic processes, but we don't have documentation. For 5 years, I've been telling Ayurvedic people, give me data on just 3 facts. What was the ailment the patient had? What was your therapy? What was the follow-up result? If you can give me for 10,000 people, I will publish it. But we don't document it.
Very important, because you tell that it is correct that when you give the healing or maybe yoga or music, actually internal chemicals are started working. Yesterday he told me, your mind, so don't break your mind. When mind is working, your chemical automatically going up.
Absolutely.
So that's what working in the healing. And there are so many results I got. Second question is that you told us that there is a metaphor this for diabetic tablet. But why after taking this metformin tablet, people are going on gagging and many people are going, I have problem also, I don't know. There is no side effect, but why they are getting? They are taking over 30 years, 40 years, the same tablet.
I've been taking the metformin for last 13 years. I'm almost taking 2 grams of it. And I can tell you that we can take green tea from mulberry leaves, and that will lower blood sugar. You can also take betaine from sugar beets. That will also lower blood sugar. Same is true of the extracts from Karela or fenugreek. and you also know of the Arjuna, and we have number of antiglycemic phytochemicals. But still we have not come up with a polypill based on indigenous phytochemicals. Unless we develop some such thing and compare it with metformin and show that our phytochemicals are as good as the metformin with less of the side effects, we cannot prove anything. Standard practice, whether it is the European Union or FDA, is whatever the new drug that you develop should be safe and as effective as the one that is already been approved. That is the standard practice. And that's why in Chennai they compared it with metformin and showed that Siddha medicine was as good as the other one. So we can start doing like that for us. What is holding up is, if you ask Ayurvedic people, they say our preparation is unique, others is different. And even if you go to herbal products and they develop like Himalaya, Ayurvedic people say that's not Ayurveda, that's a herbal preparation, it is not the Rasayana. So we have this definition itself, conflict of what we think is the therapeutic. But if you look at it, it ultimately is the phytochemical which is doing. It is not the sweetening thing or the solubilizer what you add, whatever it is, but it is the total concept of phytochemical. So we can either do testing of the Rasayana itself with metformin, if that's what they want, or we can use the concentrate of the phytochemicals in a capsule form. For example, I am trying to develop a polypill based on these phytochemicals for diabetes, because then we can at least reduce the amount of metformin I had to take, because already 13 years I have taken, it has its own toll on my liver. If I can lower it to 1 gram instead of 2 grams, that will be great. So that's the type of thing that we want to develop in the indigenous medicine. Since I chair, I would stop it at this point, and we will go on with the next presentation for the plenary session.
Thank you very much, Dr. Rao, for a very interesting presentation. I invite Dr. Wahid to felicitate Dr. Rao with a certificate.
Very bad with the side effects of steroids. I have developed some exercises by which the respiratory health problems, mainly because they relate to hypersecretion of mucus. The whole of the mucus can be drained out from the upper airway passages, mouth, nose, pharynx, the primary sites for colonization of pathogens, and also the tracheobronchial tree. So these exercises I am introducing for the first time to the whole world. I have got my videography of the exercises. Now 6 minutes video is there, loaded now. I am going to present my case now. Please study the exercises, how the mucus goes out of the upper airway passages and also tracheobronchial tree. Every patient who is suffering from common cold, sinusitis, bronchitis, conjunctivitis, asthma, and COPD, they all get relief within 20 to 30, 25 minutes, doctor. I request all of you, please study my exercises. I am introducing these exercises for the first time to the whole world. Please study, all of you, and take into consideration if there are any benefits to the patients.
Thank you very much, sir. I would like to tell you that we will have a panel discussion after this session, wherein you all are invited to put up your discussions and queries as well as your ideas. You all can subscribe to OMICS Group International channel on YouTube to view the live streaming of the session and the conference, which will be at www.youtube.com/OMICS International. For our next plenary talk, I would like to invite Dr. M.A. Wahid, Director, Central Research Institute of Unani Medicine.
Good morning to everyone. My dear friends, the distinguished scholars, scientists, students, ladies and gentlemen. I'll be talking before you today about vitiligo, which is regarded as a cosmetic problem in our society, which is regarded as a social stigma. Probably the topic goes as vitiligo repigmentation, a cosmetic need. A study with systemic and topical Unani formulations, the study was conducted at Central Research Institute of Unani Medicine, Hyderabad. This is under the aegis of Central Council for Research in Unani Medicine, Department of Ayush, Ministry of Health and Family Affairs, Government of India. My dear friends, as all of us know that the importance of the blemish-free skin to an individual's self-esteem and the maintenance of the satisfactory body image among the peers cannot be underestimated. Only the affected know the hurt occasioned by a disfiguring macule, which may not threaten their survival, but slowly and cruelly ruins their lives. Vitiligo is such, being a cosmetic problem, which is regarded as a social stigma. Probably it ruins the life rather than having major threat to their life. Vitiligo, a common dermatological cum social problem, which has affected as good as 1% of the world and 3% of the Indian population, is defined as the acquired depigmentation of skin which results from the destruction of melanocytes. Uncolored skin is visibly striking since the patient has two different colors, and which is cosmetic in nature, and it has devastating effect on the psyche of the patient as it distorts the body image and causes extreme fear, anxiety, and concern. The earliest symptom of vitiligo aroused when it appears as a white patch. Histologically, vitiligo is characterized by the loss of melanocyte with diminished or absent activity of the melanocyte tyronase or the melanin pigment or precursor, the DOPA. As I told you, around 3% of the Indian and 1% of the world population having. So 1 in 136 or 2 million people alone in the United States of America is affected with vitiligo. The female-male ratio probably 1:1, which has very significant effect on it, being in a cosmetic need. A young girl probably with a vitiligo, which has a social stigma attached to it, probably denied of the spinster, the matrimonial alliance, the first-line jobs which needs the public interaction. The commonest age among these is the 50% of the vitiligo patients develop their full vitiligo picture before attaining a menarche. Then probably another 70% of the vitiligo patients developed the fully developed vitiligo picture before attaining the third decade of life. The disorder consists of the areas of macular depigmentation, commonly on extensive aspects of the extremities on the face, neck, and skin folding areas, unilateral, bilateral, and symmetrical in distribution. The emotional distress or discrimination are usually associated with this. Now, when we talk about vitiligo, an enigma probably which cause is not known. There are various hypotheses which are postulated in the causation of vitiligo. The most common among them and the most accepted among them is autoimmunity. The another is autocytotoxicity, the neurogenic factor. Of course, the predisposed genetic factors are always there. There could be an environment factor. So in total, vitiligo is regarded as a polygenic. And the most of the cases of vitiligo which is accepted, the autoimmune cause. There are different types of vitiligo. Probably I'll be discussing with that in the during course of the talk. The majority of the cases are every type of vitiligo has its own cause, its own somatic appearance, its own regression and aggravation pattern. If you get some of the cases, classification of the vitiligo could be it is a classified. Various classifications are there. The most accepted is localized or generalized vitiligo, which is subclassified as segmental vitiligo. Segmental vitiligo is a unilateral vitiligo, is considered to be a localized vitiligo. It affects only the area supplied by a particular nerve. The common sites are the area supplied by a facial nerve, intercostal nerve, ulnar nerves, etc. Though it is a localized vitiligo, though it is a unilateral vitiligo, but it's considered to be very resistant to the treatment and stubborn to the treatment. And the repigmentation outcome is comparatively low compared to the other groups. Another is a mucosal vitiligo, which affects only the mucous membrane around the body orifices. Probably this is the most difficult to treat because to get back repigmentation over the mucous membrane is generally 1 in 10,000 chance. Generalized vitiligo probably have a acrofacial vitiligo. Acrofacial vitiligo, pointer have, okay. This is a acrofacial vitiligo. It affects only the acral areas. The acral areas, this again the cause may be probably autoimmune origin. It is always ascending in nature, and it affects the lips, the acral areas of the hands and the toes. Another is vitiligo vulgaris. Vitiligo vulgaris is a generalized type of vitiligo which is treated and probably it's not controlled. There is a rapid aggravation of vitiligo. The major part of the body gets depigmentation. The non-dermatomatous vitiligo is a type of vitiligo which is where the extensive distribution of lesions, probably 2/3 of the body is affected. It could be a bilateral, could it be a bilateral symmetrical, could it be a bilateral asymmetrical, and sometimes it can give the body butterfly image. The importance of early aggravation treatment of vitiligo, that is more important. There are two thrust areas in the vitiligo management. One is probably to control the aggravation of lesions or make the patient stable. The definition of the stable vitiligo probably is that you make the patient offer the best treatment in order to contain the vitiligo aggravation. In other words, neither patient is getting the new lesions, nor the existing lesions are increasing size. So that is a very important thing. Probably if you talk in today's language of cricket language, it's as good as if you are able to make the patient stable is as good as preparing a good pitch for a 2020 result-oriented match. All said and done, if you have a treatment model which is just not effective in terms of repigmentation, but if you have a treatment model which can control the aggravation of the lesions or slow down the autoimmune process, then probably you are doing the wonderful job for the patients. Because once it is stable, then probably n number of surgical methods can be applied. The most common among them are the punch grafting, micrografting, and the direct melanocyte transplantation can also be done. So in a shorter time, a patient can get rid of the problem. For example, for a young girl to get married, they probably one has not to go for years of treatment with a lot of adverse effect, and probably at the end of the day, you are not sure that what the percentage of patients is going to get repigmented. If you talk about a good treatment model, then probably the center, a particular center, a particular system of medicine offer the best treatment in order to get the repigmentation. When you talk with the patient's perspective and the doctor's perspective, if doctor says my treatment model is as good as 70 to 80% effective in terms of repigmentation, inducing the repigmentation, you could present a paper, you could publish the paper, you could get it recognized in the society, you could get a promotion, you could get an academic benefit. When you talk with the patient's perspective, the left out 20% or the 10% vitiligo is attached with the stigma. Vitiligo lesions are all set and then there with the patient. The stigmatized patient is stigmatized. Probably the ill effect of the society which is associated with regard to the vitiligo is always associated. So there is a great need to develop an integrated approach where you need to offer a cosmetically acceptable repigmentation, where not only should patient control the further spreading, regain the repigmentation, retain the repigmentation, and left out areas probably which is not able to repigment with the particular formulation or particular course of drug, it belongs to the particular system of medicine, should be done through an integrated approach of any surgical method. The most commonly and most safe, most effective, and result-oriented is a melanocyte transplantation testing. The onset, as I told you, the onset of disease is more common in younger population. The morbidity attached with vitiligo can be compared with the morbidity attached with a very killer disease as good as in malignancy. You know the difference between the malignancy of the vitiligo. A malignancy, it affects only a man who is in the late ages of the 40 and 50 years of life. By that time, he has already lived his golden life. He has left behind people to look after him. But since the onset of vitiligo is in a younger population, a younger girl in our society has faced a lot of discrimination with regard to the matrimonial alliance, the jobs, and the lot of psychological effects which will result into the course of development and the personal life. So the earlier initiation, there is a great importance of the early initiation of the treatment in order to control the galloping phase. Galloping phase is nothing but the aggravating phase are very active vitiligo. Probably active vitiligo is maybe because of the autoimmune origin. Is accepted that the non-dermatomal vitiligo or vitiligo vulgaris and acrofacial vulgaris, probably these are because of the autoimmunity. The best evidence of autoimmunity in vitiligo is its clinical association with other autoimmune disorders. You need to develop control. Once probably need to develop a controlling phase, you are halfway success, attaining the success and offering the best platform to the patients to receive either the medical treatment or the surgical treatment. As all of us know, vitiligo being a resistant disease, a metabolic disease, a tough disease to treat, and every new patient is a new challenge to the doctor, new biological setup, new different types of vitiligo, different phases of study. The patients are treated with the different systems, but in vain. During the course of treatment, as is a stubborn disease, patient has to go treatment for over years. During the course of the treatment, probably the patient may develop the resistance against the formulation. In spite of the new doctor, when they go to the doctor, in spite of the new formulation which the new doctor has, it may not be effective as long as you treat the patient with a resistance which has already developed because of the previous treatment. So there is a great need to develop a formulation to overcome the resistance created because of the previous treatments. And of course, everybody's desire to induce and accelerate the rate of repigmentation. As I told you, there are a good number of drugs. The treatment outcomes with the very formulation, could it be a topical or could it be systemic drugs, it will end up with the percentage of repigmentation could be 30% to 40 to 50 to 60, and in some cases, a part of the cases 100%. If not, if it is 100%, there should be need of an integrated approach, which is always required to have. In a study, I will be presenting a gist of the study which we have conducted at Central Institute of Unani Medicine, Hyderabad. 4,775 patients treated with a particular formulation which is coded as UNIM 001 plus 003. The total duration of treatment was 18 months. Patients were investigated for hematological urine and stool analysis. Hepatic renal parameters were evaluated initially and every 3 months in order to see the safety of the drug. Histopathology studies were done before and after treatment on a sample of patients, among not all the patients. Distribution of patients as their topomatic appearance and the clinical involvement in respect of the various ages as pre-adolescence, adolescence, and post-adolescence ages. As I told you, vitiligo being a metabolic disorder, it affects the younger population. We have divided these into different groups, which as the pre-adolescence, adolescence, and post-adolescence cases. At the same time, there are many factors comes during the course of repigmentation. Probably 100 patients were started treating with a particular formulation. At the end of the day, after the completion of the trial, probably the results will be in 4 categories. At 25%, it will be excellently responded. At 25% of it will be partially responded. At 25% will be not responded at all. And 25% probably there is aggravation of lesions. There could be some factor. Because vitiligo remains to be vitiligo. Vitiligo patients is the vitiligo subjects, then probably you have a good counseling methods in spite of the single formulation which is offering to all the patients. But the treatment outcome is different. So there are very factors come. The somatic appearance, the site of lesion is more important rather than the extension of the lesion. For example, entire face is white. Probably I'll be showing you some of the before and after treatment photographs. Face is a good area to get 100% repigmentation. Probably in a 10 to 12 months time. Even the entire face is depigmented, but at the same time, the vitiligo over the mucous membrane, such as over the lips, probably will not respond it at all. So when you talk about the vitiligo treatment, my drug over the face is 90% effective minus lips. If you minus lips, it is 100% effective. So these are the various and ways and means how we evaluate the patient. So age of the patient is required, where metabolic activity is very fast. The clinical involvement, like as I told you, the classification of vitiligo, like segmental vitiligo, probably segmental vitiligo treatment will be slow. The treatment, the 003 and 1, as I told you, 001 is given in tablet form orally, whereas 03 is given in a powder form. for excellent topical application. Response was evaluated as follicular and perilesional repigmentation, depigmented macule. This was the earlier study which I am presenting, but we started using the VASI, applying VASI nowadays in assessing the patient. The endpoints targeted lesion of the therapeutic outcome, assessment of the disease activity also we have done, whether the disease process is controlled, the aggravation of lesions are controlled or not, and assessment of the untoward side effect also. The important thing I will tell you, when we evaluate the response, some patient may respond, there could be a spontaneous repigmentation. Some patient may respond faster to the treatment. Some may not respond at all, and some may respond very slow to the treatment. In order to know the effect of the drug in different ages, different types of vitiligo, different somatic appearance, different distributions of lesions, we have done the assessment of the patients as quickly responded, slow responded, not responded, stationary vitiligo, aggravation lesion, etc. I'll just give some statistics to you that around as good as 43% of the cases were below 16 years of age, and 62% of the cases below 24 years of age, and as good as over 76% of the cases over 3 decades of life. This is age at treatment. When we talk about the duration of disease, the chronicity of disease also plays a vital role. It has inversely affected the more the chronicity, probably the lesser the therapeutic effect. So over 70% of the patients for 1 to 5 years of the chronicity, that speaks the importance of the magnitude of the problem, that being a cosmetic problem, every patient as early as want to get rid of it and wanted to seek a treatment. When we distributed the cases as per the somatic appearance, then we had as good as 25% cases of localized vitiligo, and around over 74% of the cases with generalized vitiligo, out of which we had over 14%, as good as 15% say the segmental vitiligo, and the 11 are mucous vitiligo, which are regarded as more resistant to the treatment. Where acrofacial vitiligo, we had around 20%, over 9% vulgaris, and non-dermatomal of vitiligo is over 52%. And the generally majority of the patients do have either the non-dermatomal vitiligo or the vulgaris. And the merit and demerit of this particular type of vitiligo is, the merit is tend to spread fast. The merit of it is they tend to repigment fast. See, this gives the age of the patient, age at onset, the duration of disease, and duration of response, duration of treatment and response to the treatment in a particular type of vitiligo, that is segmental. Since the outcome of the treatment depends upon the somatic appearance of the lesions, the type of vitiligo, distribution of the vitiligo, and extension of the vitiligo. So based on that, we try to vary the initiation of the pigmentation within the 3 months of therapy. And some of the cases, there is an aggravation of lesions also among non-dermal vitiligo. That makes the sense that segmental, mucous, and acrofacial vitiligo, you can start with the treatment, where you can try to induce as much of a repigmentation which is achieved. Once the further repigmentation is stopped, probably patient can be referred with a stable vitiligo certification that he is a fit for a surgical method, so that an integrated approach can be adopted, where you can induce cosmetically acceptable repigmentation. This is not in the case of non-dermal vitiligo, because non-dermal vitiligo affects a larger part of the body, majorly extensive type of vitiligo. The definition of the extensive vitiligo is, if it is 2/3 of the body surface is affected, probably it is a bit extensive vitiligo. So extensive vitiligo, to get repigmentation, the way tend to aggravation of the vitiligo, which needs a prolonged treatment to continue the further process, to induce the repigmentation. Even the left out area, to apply the surgical methods, you need a larger donor area. There is a fair risk of chance that you may induce the repigmentation there. So we need to concentrate in such an areas, because this affects the majority, the 70% of the vitiligo patients, or either the non-dermatomal vitiligo or the vitiligo vulgaris. So this is a thrust area to control the further spreading, to induce the drug, develop a good drug to induce the repigmentation. We want to see the effect of the duration of disease, that is chronicity of the disease on the different types of vitiligo. So we have divided all the cases between onset less than 2 years and onset more than 2 years. So almost all the cases are responded, but the duration of disease has definitely the effect on the treatment outcome, probably early the onset, rapid the recovery, the late the onset, the delayed the recovery. These we wanted to give the demonstration of the response during the various course of therapy, which we have done at every 3 months. The follow-up was done and everything. There is a clinical follow-up, good laboratory follow-up also. The clinical follow-up, we wanted to show which type of vitiligo has responded continuously or rapidly or slow responded. So the non-dermatome vitiligo has responded definitely better than the other types of vitiligo. Whereas this type of segmental and mucous vitiligo have very slowly responded. And the quantum of repigmentation is definitely high in the non-dermatomal vitiligo than the segmental mucosal vitiligo. So this is the mean age and chronicity type of vitiligo, site of lesion and repigmentation with him. As I told you, the site of lesion is more important rather than the extension of the vitiligo. The common sites with the cheek, this is cheek actually, cheek, leg, chest with the segmental vitiligo have responded over 50%. The lips have responded less than 40%. And the non-dermatomal vitiligo with a major area, the extensive areas like scalp, face, limbs, and trunk, major part of the body is affected. They have responded over 65%. That is as good as 85% also in some of the cases. This is in a nutshell. Around 9% of the cases are responded over 70% repigmentation. Around under 37% of the cases have responded over 50%. Probably if you mix up both the group, then 37 and 43 as good as 40 over 43 patients have responded to the extent of 50% regain in their depigmented macules, and another 60% response within the 40% range, probably which needs a surgical intervention when they are stable, their vitiligo is stable. Around 16% of the cases have not responded to treatment. These are some of the histopathological slides before and after treatment. You can see the melanocytes forming. See this is a segmental vitiligo. As I told you, this affects only the localized vitiligo or affects only the area supplied by a nerve. This is the area supplied by a facial nerve. You can see before and after photograph. These are cases of acrofacial vitiligo, which are very resistant to the treatment. You can see the partial improvement. Another case of the segmental vitiligo. Another case of non-dermatomal vitiligo, where you can see the rate repigmentation is as good as 80%. This is another case of non-dermatomal vitiligo. The scalp is almost repigmented. Limbs are partly repigmented. Face is over 80% repigmented. You can see these girls. Again, the non-dermatomal vitiligo, both the forearms are normal, regained completely normal pigmentation, and you can see the texture of skin. There is no damage to the texture of skin. That is the beauty of this herbal formulation, that when you compare it with the treatment available across the systems, then cortisones, if you apply for a longer time, probably degenerative change starts taking place. The probably texture of skin is regained, the texture is completely normal. You can see these forearms. As I said, the site of lesion is more important rather than extension of the lesion. You can see over here, these areas are very resistant, which is partially recommended. And at the same time, both the limbs, the shin area is normal, as good as 90-95%, whereas feet, it's still repigmenting. You can see this is a non-dermatomal vitiligo, excellent repigmentation, as good as 100 repigmentation over the entire face. You can see this girl. This is a non-dermatomal vitiligo. Face is a very good area to get. Around the eyes, you say this is the first photograph. This is the first photograph you can see. Then you can see the initiation of the repigmentation when we start treatment. That's what I was speaking. They are quickly responded, where there is initiation of the repigmentation only within the 3 months of therapy. It could start as the islands of repigmentation, or there will be pre-lesional repigmentation. You can see the further the repigmentation started expanding. Then further you can see probably the repigmentation, you can compare between two photographs, that the next photograph is 100% recovery with excellently maintaining the normal texture of the skin. Thank you. Any questions? Then probably I'll answer.
It means that in some cases it may work for 100%.
Non-dermatomal vitiligo, though I told you, extensive type of vitiligo, but it affects the major part of the body, though is called as extensive, but they are excellently responded. And the repigmentation initiation is also early, and it will continue. The majority of the patients respond very well. But you put together, evaluate all the cases, probably 70 to 80% of the patients will respond full. The rest may not. And as I told you, the site of lesion is more important. Certain sites are regarded as more resistant to treatment, like lips, the palms, fingertips, toes, feet, sole, etc. So when you take into the account while evaluating the cases, all these areas, probably these areas are hardly responding.
Thanks God that I met at least to you, because I was thinking it is not curable. I'm telling all the people, many people comes to me, I said it's not curable. If you take more medicine, you will get more whiteness in the body.
No, it's not like that. It's not.
I've seen many people who have taken the medicine, they have become completely white. So I said, tell them.
No, I'll tell you one more thing. You see, though it affects the younger population, there's a fair chances of I told you, during the effect of the duration of treatment, duration of disease, there is a chronicity of the disease. Early to get rid of this problem also. So in elderly patients, probably when take disease for a longer time, more extensive, they don't want to have any treatment for a year or so, they can use camouflage and cover it up. But it's not that the more treatment you take, more aggravation it takes. It's not like that. There is a myth.
But generally, how much time it takes to...
It depends upon the type of vitiligo and the site of lesion. These are the two important areas. Probably non-dermatomal vitiligo with as I said, with the site of lesion over the face, probably a year is a good time to get repigmentation.
But they have to come regularly, or they can take a...
No, there's no acute problem attached to it. We review once in 3 months to them. But the doctor has always access to them.
Because I've got people all over the world like this.
No. With the technology advancement, probably you can review through...
I can recommend your name, please. That's better. Thank you very much.
All right.
Yeah, I have a question. Here.
Yes, please.
Excuse me, I have a question over here. What kind of preclinical studies have you done prior to starting the clinical trials?
Preclinical, see, this is basically a research center. We do the preclinical safety studies. In other disease models, we do the preclinical efficacy studies also. But here we do the preclinical safety to the extent of acute, subacute, subchronic, and chronic.
So no
safety.
Efficacy study is done. It's only toxicity data.
Sorry? No, this is a clinical study. We have not presented a preclinical study. This is a clinical study on the human subjects.
Okay, thank you.
But we do preclinical safety in terms of acute, subacute, subchronic, and chronic studies. We also do. Yes, please.
My question is, two questions. The first is, how long of a period?
Please use mic. It's not working.
Okay. How long of a period did it take for these patients to actually show the kind of spectacular responses that you have on these slides?
Sorry?
How long was the treatment period? Or the time it took for them to respond like this?
I'll tell you. It varies. See, I told you the number of things comes during the course of repigmentation. Probably the age of the patient, site of the lesion, type of the vitiligo. So these are all duration of period of time varies from person to person. For a segmental vitiligo, probably on an average 2 years. The non-dermatomal vitiligo, probably much lesser than that, 1 to 1.5 years. But with the lesions over face, when you talk about the site of lesion, probably face on the patient, the lesions over the face, trunk, and the lips may take a year time.
But for this particular study,
this girl,
what was the duration of the clinical trial?
I've already showed that is 18 months.
18 months.
Yeah, we have conducted these studies for 18 months.
Interesting. Thank you.
Thank you, sir, for your presentation, sir. Please, sir, I want to look at slide number 2, sir.
Sorry?
Slide number 2.
2. You want slide number 2?
Yes, sir. Yes, sir. That word, dopa, is it dihydroxyphenylamine or phenylalanine? I just want to seek for clarification, sir. Is it dihydroxyphenylalanine or
Alanine, is it alanine only?
Or amine?
No, alanine.
Okay. All right. Thank you.
It's alanine. Thank you. Is there any more questions? Thank you.
Thank you very much, Dr. Wahid, for a very wonderful presentation. Now I would like to invite on stage Dr. Manikonda Rao for his presentation.
See, doctors, I would like to inform first to see I am not a doctor. I am an advocate by profession. I am now at 75 years. I am a patient of asthma for the last about 45 years. Having suffered very badly the side effects of medicines, particularly the steroids, I have devised exercises myself and started introducing to the people. I am now attending the various health camps and also treating patients along with doctors. The patients suffering from respiratory diseases, which are outcome of hypersecretion of mucus, they are getting relief within 15 to 20 minutes. One patient of asthma who was suffering for the last about 20 years, he has come to me, I treated him, he got relief within 20 minutes. A person suffering from asthma for the last about 10 years, he says, I got relief within 10 minutes. So please now proceed and see the video of 6 minutes and study the mucus, how it goes out of the mouth. That is my request to you all. Airway mucus hypersecretion management through exercise interventions. The objective of the paper is to create awareness among people about alternative and complementary methods to control respiratory diseases. Diseases cause the following changes in airways. Inflammation in the physiological process plays the role of immunological defense against infection, injury, or allergy. Hypersecretion mucus is the result of goblet cell hyperplasia and respiratory mucosa and is a prominent feature of inflammation. It is a major pathological feature. Bronchospasm is the initial factor in asthma patients that lead factor to cause breathlessness. Please remember this extract. According to Dr. Sarah Herrick, a research fellow, Dr. Robin Gorey, a consultant in respiratory medicine and research fellow, and Dr. David Thornton, a senior lecturer in the Faculty of Life Sciences, Manchester University, who were conducting research 2008 and 11 as a team into the factor of hypersecretion mucus and abnormal mucus production. Production of mucus in the airways is a major contributor to the pathology of asthma as well as other debilitating respiratory conditions such as cystic fibrosis and chronic pulmonary obstructive disease. They opined that no mucus-directed therapies are available for asthmatics, and the factors that lead to excessive mucus secretion during both chronic and severe asthma are not understood. Even now, efforts are being made to find out therapies all over the world. In these circumstances, my suggestion that is, clearance effects of mucus becomes an extremely important factor for airway integrity. Exercise or therapeutic tools. They are mucokinases. They help in cleansing the adhesive mucus from mouth, nose, pharynx, the primary sites of colonization of pathogens. Sinuses, the way stations to the brain and the bronchial airways. They reduce C-reactive protein, resulting in reduced inflammation. Exercises strengthen the remodeled airways and reset the biological aging process. Upper airway passage cleaning exercises. Number 2, bronchial airways cleaning exercises. Number 3, physical aerobic yogic exercises. Upper airway passage cleaning exercise. These exercises should be practiced with hypertonic solution, a solution having greater osmotic pressure than that of cells or body fluids and draws water out of cells, thus inducing plasmolysis. The solution should be warmer than that of body temperature, that is more than 37 degrees Celsius. Better results can be achieved with 40 to 41 degrees Celsius. They are based on inspiratory. This is bronchial airways cleaning exercises. They are based on inspiratory and expiratory reserve volumes of the patients and forced expirate techniques. They help in draining total mucus from upper airways. Physical aerobic yogic exercises strengthen the inspiratory muscles and make the airways flexible. Any mucus-related respiratory health problem commences from upper airway passages and spread to tracheobronchial tree as they constitute only one pathway. The mucociliary clearance mechanism becomes defunct when excess and sticky mucus forms. Once they are cleaned, the defunct cilia become active and ciliates mucus towards respiratory passages. Nasal passage, it can be blown out easily. The bronchial airways cleaning exercise help in draining out total mucus from airways. The respiratory and the diseases containing its originating from its pathway come under control. The exercises are based on the concept. Once the offending factor, the excess mucus is removed, the origin of it, the inflammation gets resolved. This is my concept. Now I am treating patients. I have treated more than 500 patients. Not a single patient said, I have no relief. I request all of you to see the video, how the mucus goes out of mouth. That is for 6 minutes, please. Just open it. Yes. No. Patient of asthma for the last about 45 years. I am at 75 now. I am able to sleep without any symptoms of asthma today. Please, I request all of you members, close it. Please spread the message of exercises. Now see, I am on the way of developing some more exercises, 7 to 8. And shortly there I am going to finalize the exercises by which the senior citizens 60 years and above can get relief within minutes. The whole of the mucus from tracheobronchial tree and the upper airway passage can be thrown out within minutes. I am going to show at the AIMS. I have got to see next session at AIMS. I have sent my paper to the All India Institute of Medical Sciences. Dr. Meena has said, Mr. Rao will provide you 20 minutes PowerPoint presentation. You explain your concept of exercise to the delegates. Now, any questions? I am ready to answer.
What is the concentration of sodium chloride used? What is the volume to be taken from the nose?
Yes. Please remember, this system is based on one thing. Living cells are osmotic systems. They shrink in hypertonic solution, swell in hypotonic solution. This is a concept expressed by Dr. D.J. Cook of London, please. Now the point is, what I am using is warm water. Warm water, our body temperature is about 37 degrees. I am using about 40 degrees, 41 degrees Celsius, warm water, and I am putting, what sodium chloride crystals, say 1/4 in 200 ml glass, and asking the patients to snort, keep it in the nasal passages, entrance, and snort it. The water goes deep into the nasal passage, affecting the turbinates here. The turbinate where there are openings. What are the openings? Sinus openings, eustachian opening, and also nasolacrimal duct. Those openings also, if they are inflamed, the inflammation in the parts comes under control, and the water enters the pharynx. Pharynx, it takes U-turn, then enter the oral cavity. Then see, I am asking them to spit it out. And you must bend down. How much? 60 to 70 degrees. Otherwise, there will be some problem. So when you bend down, there is no scope for the water to go into the lungs. That I have now treated 500 patients. No patient has complained. 10 years, boys and girls, I have treated them. They are getting relief within minutes through these exercises. And you see, this is the only one exercise which you are seeing now. There are about 7 to 8 exercises by which you see these problems can be brought under control within minutes. My request is, if you conduct a special program, or if you invite me, I will come and I will discuss with you, and I'll show other exercises also after the conference is over next month.
How much quantity required?
200 ml water, 1 glass of warm water, 40 to 41 Celsius degrees. it should be more than body temperature. That is 37 degrees, what I have studied. And you see, the sodium chloride, please remember, I am not a doctor, but I will try to explain a few points here. What is the sodium chloride? It is an ion. It contains what? Proteins, neutrons, electrons. Proteins, they are charged. Electrons, they are charged. When we take the hypertonic solution like this, they conduct electricity across the mucous membrane. As a result of it, the heavy excess mucus formed in the nasal mucus in the cells, the sedity mucus comes out because we are using hypertonic solution. The solution inside is hypotonic solution. They are at this side, they come out, and you feel easy to breathe. And I'm asking patients to use little decongestant, Otrivin C nasal drops. Why? Because the nasal mucosa, the blood vessels in the nasal mucosa get dilated as a result of inflammation. So therefore, that is a dilation, and as a result of taking these nasal drops, they get constricted, allowing the patient to get easy breathing. So as addition, I am taking that. That's all.
Yeah, I have a very fundamental question to you, Dr. Rao. I think you're doing something, but did Indian Medical Association or Indian Medical Council permit you to do this? Because you keep telling you're not a doctor. You cannot deal with a human body, non-medical. So anybody on the street can do that, no matter how good your device, but we must follow ethics. So I do not know how you may be in a difficult,
Yes.
in any Western country, will very highly criticize Indian Medical Association, even allowing you to do this.
One thing I would like to see, one or two doctors asking me this question. What he said is, you are number one enemy to the doctors. Your system, your practice, your methodology affects our profession, he said. Yes, doctor, I am very sorry. Because all patients cannot afford to pay so much. But there are also ethics, you must follow it. But Baba Ramdev is not following any ethics, they are exercises. Should people who are practicing exercise, should they go for ethics? Where is the law for it? I am an advocate by profession, I am asking. Are they covered by the ethics exercises? Sorry, doctor.
Well, I do not know that, but I can only look at it that a human body, you must be qualified in the practice of medicine. It cannot be allowed. I shall not allow, even in being in India, I shall not allow you to do that. I shall highly protest what you are doing.
If anybody prosecutes me, I am ready to face in the court. I am an advocate by profession.
Sir,
I am serving the people without taking a rupee, single rupee.
Sir, we have a panel discussion later after this session. So maybe we can have these discussions afterwards.
Yes, thank you very much.
Yes,
Very
sir.
kind of you to be here.
I request Dr. Wahid to felicitate Dr. Rao with a certificate. Dr. Manikonda Rao. So as we begin with the session for this day, I would like to introduce our chair, Dr. Gundu H.R. Rao, who is a professor at the University of Minnesota. His brief biography, he obtained his BS degree from University of Mysore and BSc and MSc degrees from the University of Pune. He obtained his PhD from Kansas State University. He worked as a tenured professor at the Lilial Heart Institute for over 3 decades. He is the founder CEO of SASAT, GATHS, and Mind, Body, Spirit of India. He has published over 300 research articles currently, and he is currently working as an emeritus professor at the University of Minnesota, USA. Please welcome, sir. So please hold your chair position. Now I welcome our co-chair of the day, who is Dr. Mohammed Abdul Wahid. His brief biography, He is currently working as a director at the Central Research Institute of Unani Medicine, Hyderabad, India, and he has published many papers on Unani medicine in international and national journals and attended national and international conferences. He has presented more than 40 papers as authors and around 20 papers as co-author. Vitiligo being his topic of interest, enormous contribution is done by Dr. Wahed, concerned with vitiligo in delivering lectures, conducting workshops, contributing research papers, and he has also got knowledge on remedies dealing with vitiligo. Please welcome, sir. Please hold your position as the co-chair. Before we begin the session, I would like to invite Dr. Rao to felicitate Dr. Wahed with a plenary session certificate. So just a moment, photographer is on the way. Our topic of discussion for this session would be aspects and applications of traditional medicine and Unani medicine. But before we begin the session, I would like to request all the speakers to please compile their presentations in 15 minutes so that we can give ample amount of time to the panel discussion at the end of the day. I thereby request Dr. Rao to open the session.
Good day, everybody. We will get started with the session of this morning. And it is... She asked me to do something. Anyway.
Okay. Thank you so much, sir. Now I would like to call our first speaker of the day, who is Dr. H.N. Shivaprasad, Vice President, Olive Life Sciences, India.
Good afternoon, everybody. The topic of discussion is a traditional and alternative system of medicine, inspired approaches in developing clinically validated herbal nutraceuticals. As you know, the herbal nutraceuticals are gaining a lot of importance in the international market, and the growth is almost $95 billion expected by 2015, especially the markets like US, Japan, Australia, and European market, and even the Asian countries like Taiwan. We are exporting a lot of herbal extracts, standardized herbal extracts to these international market, and the growth is tremendous. So when we go for exhibition, when we meet clients in the other countries, they are very much interested in the traditional and alternative system of Indian system. And this is making us to develop new nutraceuticals from the leads of traditional system. So I'll just give a case study how we developed a nutraceutical standardized herbal extracts based on the traditional lead. So as you know, the herbal drug discovery process involves a multidisciplinary approach, which includes ethnobotanist, botanist for a proper identification of the medicinal plant, and also includes a phytochemist, very importantly, to identify the active components which are present in the plant, and taxonomist and pharmacological department, and pharmaceutics for the development into formulations. So in every aspect of development of a new nutraceutical, it starts with the lead identification. In traditional system, there are a lot of medicinal plants have been reported for various applications, and this is becoming a lead for most of the herbal industries. So it is saving a lot of money, time, and resource in development of a new nutraceuticals. So we identify medicinal plants based on the functionality. For example, if we are developing a nutraceutical for the blood sugar management, we identify those plants which are reported for madhumeha, that is diabetes. So we then we list out those medicinal plants based on the priority and based on the importance, and also on the some important criteria like whether it can be cultivable, whether it is having any any issue with the availability of the plant species, whether it is RET. All these aspects are considered while selecting the lead. So this is a very important step, and which is giving a lot of advantage to the herbal industry to develop new nutraceuticals to the market. So as you know, other steps involves phytochemical analysis, followed by in vitro, in vivo bioassays, then finally a clinical trial is must. So traditional system is becoming a new discovery engine, and it's a rich in knowledge base. The systems like Ayurveda, Siddha, Unani, homeopathy is giving lot of leads for the industry. So based on that, every industry is creating a libraries on these leads, and they are standardizing these extracts with respect to safety and efficacy part. So as I told earlier, it is giving a lot of benefits in terms of time, money, and toxicity, very importantly, because if the lead is having already a food use, which always stands up first in the lead. So new nutraceutical product development happens in this way in the herbal industry. First is the identification of the lead, followed by a preparation of the extracts. These extracts will be standardized in vitro mechanism based on the active molecule present in that. And then various fractions will be collected. For example, if it is an in vitro diabetic study for a development of a blood sugar management ingredient, we screen it in various assays like alpha glucosidase, alpha amylase, PTP1B. Lot of in vitro assays are there which can give an answers in a quick manner. So we use these plant extracts and fractions to test in those in vitro assays, and we come to a conclusion on the fraction which is responsible for the activity. Finally, the extracts will be standardized with reference to that active molecule, and then it will be subjected to animal study, and finally clinical validation will be done. So overall, what I want to say that the traditional leads is playing a major role in giving easy answers to the drug development. I mean to say the nutraceutical development. So as I told, it's a multidisciplinary approach which involves phytochemistry, traditional data, ethnobotany, then formulation, clinical research, and bioassay. So I'll just put a case study here. We have developed two ingredients, nutraceutical ingredients, and launched in the international market, mainly in Taiwan, Japan, and US. These two leads have been developed based on the pre-diabetes and mild to moderate hyperlipidemia. This is a major concern in the world market, and in nutraceutical segments, this stands in the number 5. So the United States, if you take about 28 million people are suffering from diabetes, and almost 77 million people are pre-diabetes. This is a pre-diabetes is a concept where people are healthy, they are not considered to be a diabetes, and they are not put on any medication, but still their blood glucose level will be fluctuating between 120 and 140 frequently. Plus they will also have a mild to moderate hyperlipidemia, wherein which the total cholesterol will be above 200 and LDL will be more than 169. But normally the doctors will prescribe them to go for a therapeutic lifestyle management, do exercise, cut down the food and all those things. That is the recommendation. So this group is becoming bigger and bigger because of the lifestyle in the Western population, even including in India. So this is where the nutraceutical market is there for this group. So based on these data, we started identifying, what is this? Okay, no problem. So based on this data, we started identifying the lead from the traditional system. So we collected the lot of leads from the traditional system, and then we started working on that. So finally, it matters with what type of clinical study we do, because to convince the regulatory authority in those countries. So we did a clinical study. It's a well organized study, needs to be registered in various authorities, which I will be showing here. So CTRI is now mandatory for all the clinical trials, should be registered in Clinical Trial Registry of India, which is managed by National Institute of Medical Statistics. Then clinicaltrial.gov, it's a US National Institute of Health which maintains the registry of all the clinical studies conducted. So it is, if we are launching these products in US market, it is must to register in the clinicaltrial.gov. Similarly, UMIN is a University of Medical Information Network from Japan, and World Health Organization, it's an international clinical trial registry firm. Why these things are important for the publication and to go more and more countries to approach our Indian traditional system, the clinical trial should be registered in these type of platforms. So they review the protocol and they approve the trial for the further action. So coming to the traditional lead for pre-diabetes and mild to moderate hyperlipidemia, we screened many plants, and then was in the classical text it was mentioned as Madhumeha. The team we have in our company, the traditional team, they selected 10 to 15 plants in the leads. One such plant which came out in a very, it's already sold in some of the countries, very prominently is Salacia. Salacia reticulata has been used in Ayurveda and traditional Indian system of medicine for Meduroga and Madhumeha. And it is also in Ayurveda, the literature's classic books mentions that person suffering from diabetes should drink water left overnight in a mug carved from Salacia. So the water soluble fractions of the roots and stems of Salacia have been identified to as a potent alpha glucosidase inhibitor. So this is one review from the literature we found, and then we started standardizing this extract. There is a patent from Japan on salacinol and cotenolol, the two active components which are responsible for this alpha glucosidase. So we left that part aside, and then we started doing a bioassay and phytochemical analysis, and then we found an interesting molecule with a 10% polyphenol, and we made a different fractions, and the 10% polyphenol and 1% mangiferin based extract was showing a very potent activity in alpha glucosidase inhibition. So this made us to go further depth. So this is an overview of carbohydrate metabolism. The polysaccharides which is getting converted into disaccharides, maltose, sucrose, and then the simple sugars, glucose, fructose will get absorbed into the liver. So alpha glucosidase is an enzyme which converts the disaccharides to monosaccharides. So if we inhibit the step of alpha glucosidase inhibition happens, there will be a limitation of absorption of the glucose in the liver. This is the basic mechanism of alpha glucosidase inhibitors. Based on that, we found the IC50 value was very potent for this particular fraction of Salacia. Then we did a preclinical studies and toxicity studies. There are a lot of studies have been reported, but since this fraction is a new one based on the polyphenol rich fraction, so we did a toxicity studies. Then we did a clinical study which has been approved by CTRI and other authorities. This study consisted of 500 mg per day dose for 6 weeks treatment for subjects who are suffering from pre-diabetes and mild to moderate hyperlipidemia. All the subjects were in the blood glucose level of 120 to 140 ml per deciliter, plus the overall total cholesterol was more than 200, and main target was LDL cholesterol, which is between 169 and 180. So that is as per the ATP, American Treatment Panel, guidelines. We recruited the subject, and we started administering the capsules of Salacia twice daily. And we saw there was a drastic and statistical decrease in the blood glucose level and LDL cholesterol. This is a table which shows LDL cholesterol reduction in 3 week and 6 week. And this is the reduction of fasting blood glucose in 3 weeks and 6 weeks. So we applied for a claim in EFSA, European Food Safety Authority, and in US FDA for supports healthy blood glucose level and maintains healthy cholesterol level. The claims have been approved by EFSA, and now we are moving ahead with the selling of product in the European market also. This is already popular, we are selling in Japan. So I just want to tell you how we develop this from the traditional lead to make it more popular in the international market. This is the publication of our clinical study in Journal of Medicine and Food, which is a Korean Society of Food Science and Nutrition. Now we are in registration of the Salacia in Korea also. It is not registered yet. So it is been under registration of Korean Food Drug Authority. So this is a compilation of other clinical studies in the about Salacia reticulata, but most of the publications have not revealed what is the exact standardized part of the extract. So there is a study on 51 type 2 diabetic subjects showing a reduction in the glycosylated hemoglobin, and also there is a 6-week administration of study on 20 type 2 diabetic subjects. There are a lot of preclinical studies, and another interesting thing is there is a study which shows that reduction in the body weight also on the obese rat model. That is also very interesting, and now we are looking into that aspect also. Similarly, there are number of preclinical data available on Salacia reticulata. When it comes to safety, a safety study, we also have done 90 days toxicity study. We have done chromosomal aberration Hames test for the extract which we have fraction which we have done. Similarly, there are a number of studies available on the Salacia reticulata for different fractions in the literature, modern scientific literature. So these are some of the formulations in the international market having Salacia reticulata. Different manufacturers use their own trade name for promoting the extract. The another one is sesame seeds. Sesame seeds are traditionally known for reduction of cholesterol, and then we started working on this, and this is the brand which we have given as Sesavita in international market. It's been trade named in US FDA. So similarly, we did a clinical study on preclinical pre-diabetics and mild to moderate cholesterol hyperlipidemia subjects, and we found the study when compared to Salacia, it was not so significant, but when compared to placebo group, it was showing effect in the 6th week. Why we give more importance to this ingredient? Because it's already consumed as a food. So regulatory wise, this is very easy to approach the authorities. So we worked on this particular ingredient, and we standardized the extract with sesamin complex, that is sesamin and sesamoline lignin complex, and 2 more new identified new compounds which we are still working on that to make the standardized extract with 4 different lignin complex. So this is also been published in Journal of Food Research. It's a Canadian journal. Then similarly, the compilation of various studies, clinical studies targeting the cholesterol and blood sugar level. There are publications on even managing the blood pressure also. So these are the preclinical studies. In safety studies, there was a reported LD50 of more than 5000 mg per kg. As you know, it is highest safety margin which is available. This became a major criteria for selecting this type of ingredient in terms of regulatory wise. So, and genotoxicity, all that safety parameters have been defined. But the fraction which we have made with 2 lignin complex and 2 more unidentified compounds have not been studied. So we did all preclinical toxicity studies before we started the clinical data. So lot of nutraceutical market is having lot of ingredients, a lot of formulations with sesamin as a major ingredient. So these are the major 4 portals in nutraceutical market in the world. Mainly Nutra Ingredients and Natural Product Insider, Nutraceutical World. These are the one which are promoting Indian herbs in the nutraceutical market, very popular. So all our clinical study and our whatever toxicity studies which we have done, all have been covered in these magazines, and which helped us to move further in promoting these ingredients in the international market. So now the latest development is we are also now catering to the Indian market with a beverage made out of these 2 ingredients, so which is still under the process, and we are working with a local manufacturing companies like Dabur and all. We are approaching with these leads. So what I would like to conclude in brief is globally there is a positive trend towards holistic health. Lot of whenever I travel outside, lot of people express their interest on Indian traditional system and they want to know. But only the limitation is a standardization and their regulations. So if we can make it in their approach, and if we can standardize and define the extracts in more clear manner, I think we have a better chance in the global market as well as in the domestic market. So leads from traditional system of medicine will have real discovery engine, and it is serving us very greatly, reducing a lot of time, and it is also cost effective in developing a new nutraceuticals to the market. It will be an interest of pharmaceutical companies. A lot of pharmaceutical companies, even recently Aurobindo also started working with an herbal extract company. I think they are buying an herbal extract company. They are going to launch new extracts to the international market. So a lot of pharmaceutical companies are also looking towards traditional leads to develop new nutraceutical. So these are the references, and thank you for giving this opportunity. Any questions?
Thank you very much. It was a very nice work. We would like to see more and more of this kind of work because, as you very well know, there are many, many antiglycemic phytochemicals, and they are all of great importance to us. We did a study recently on green tea from mulberry, which also is antiglycemic, and trimethylglycine from beetroots is also antiglycemic. So there is a great opportunity for us to come with a number of phytochemicals which are effective and which also can reduce the side effects that we have with some of the Western medicines. So anybody has a question for Dr. Shivaprasad?
Growth is tremendous, sir.
Yeah.
Hi, I'm Kaushik. I liked your presentation very much. My first question is you selected a particular herb. How you why you selected that particular herb? Whether it was based on a systematic review or something else?
Yeah, it is based on the systematic review. We shortlisted around 10 to 12 herbs. 10 to 12 herbs. Then further we put certain criterias like food use, already existing safety profile, then whether it can be standardized, and most importantly cultivable, because the nutraceutical market is volume wise it is very big. Anything supply, it goes 5 tons, 10 tons of extracts per month. So very importantly whether it can be cultivable. So Salacia is one certain concern is there, but still we have initiated the cultivation of this in the waste forest lands, and the forest department also has come forward. So we selected these criteria to identify the leads. So when it qualifies all these criteria, then we started working towards that.
And what was the sample size?
Sample size was 30 subjects. 30 subjects in each trial. And 15 in placebo and 15 in the treatment group.
So you did some sort of sample size calculation?
Yes, yes. Based on the preclinical data, I have not put that slides here since the time was very less. So based on the preclinical data, we did a sample size calculation.
And are you planning to, whether you did economic evaluation, cost effectiveness?
Pardon?
Economic evaluation, cost effectiveness of this particular medicine?
Extract, yeah, this
cost effectiveness, economic evaluation.
On the trial part or on the final product?
Final product, basically.
Final product, always the standardized extracts are very expensive because the percentage of yield assay, when you extract a 1 kg, you will get normally 2 to 3% yield, sometimes maximum 10 to 15%. So cost wise, it always little expensive, the standardized extracts.
So you haven't done any economic evaluation, proper economic evaluation?
Economic evaluation we have done, and we are offering in the international market, the extract. Per kg cost.
Okay. Thank you very much.
Thank you very much. If you don't have any other question, we pass on to the next one. The next presentation. Thank you very much.
Thank you.
The next presentation is Dr. Rajesh, Indian Institute of Horticulture Research, Bangalore, India. The title is Indian Medicinal Plants and Related Traditional Knowledge. Is it the one? Is it the correct title?
Good afternoon, respected chair and co-chair and distinguished participants.
Comparative study.
For the last 2 days, you have been listening a lot on traditional medicine and the related aspects. So I would like to take you to some other aspects of this knowledge. Just now you heard the previous speaker how we developed a nutraceutical from Salacia reticulata. In fact, the lead he has taken from the traditional knowledge. So the knowledge belongs to the community, and whether you are paying back to the community or not. So what are the legal aspects? So I would like to take you to these aspects in my presentation. So the title is like this: Indian Medicinal Plants and Related Traditional Knowledge, Modalities of Protection from the Intellectual Rights Perspective. So in my presentation, I would like to share these aspects. I'm not going to read all this. See, as far as the medicinal plants are concerned, there is a huge market is existing, and here in this slide we are given the number of medicinal plants used by different countries. You can see in India we use a lot of medicinal plants. In fact, out of 18,664 plants, 3,000 plants are having the medicinal properties, that is 16.1%. And China also using a lot of medicinal plants for different purposes. So we have a very, as all of you know, we have a very rich biodiversity in medicinal plants. 6,200 out of 15,000 plant species in India are known for their medicinal uses. And more than 4,269 ethnic communities use them for human, veterinary, and crop health. This gives a lot of information and knowledge. And more than 150,000 formulations are known to be documented so far. So India is also one of the hotspot of biodiversity, and 12th richest country in the world as far as the biodiversity is concerned. And the Western Ghats, including Sri Lanka, is considered as one of the richest hotspot of biodiversity, and it is very rich in biological resources and traditional knowledge, and exploited from wild resources, and many of them are even overexploited, and many of these medicinal plants are finding a place in the red data for IUCN. Then place of origin of some of the medicinal plants that is used in the traditional system. You can see from this slide that it is originated in different places, but it is finding a place in Indian traditional uses, most of these medicinal plants. And from agricultural society, now we are moving towards the knowledge society. In that process, the technology, networks, and innovation plays a great role. And the traditional knowledge also plays a great role in transforming the societies as far as the treatment of the different ailments are concerned. So now coming to the IP, that is intellectual property, this information is taken from the United States Patent and Trademark Office data available online. That, see, we find most of these medicinal plants are in the, as a reference in the many patents in USPTO. So what does it show? This shows that these resources are not there with them, but the knowledge is patented in different ways in US. And why this happening, how to prevent this, and what India is getting out of this. And the TRIPS, the trade-related intellectual property of WTO, there is a provision to give the wrong patents or the bad patents. In that also you can see that so many countries have given the wrong patents in different biotic resources. So the question is, who owns the plant wisdom, the information available on different plants? See, the pharmaceutical and industries are now waking up to the enormous profit potential in unexploited chemical and genetic diversity available with the plant kingdom. And now the race is on to identify and patent as many novel genes and plant products as possible. And before the species disappear or their habitat destroyed, many of these discoveries are based on knowledge collected over centuries. As I told you, this knowledge belongs to the society or knowledge belongs to the community of the indigenous people. Are they the owners of this knowledge? Should they be compensated? As I told you, now so many leads are available in the traditional knowledge, and many modern products are coming. So the community should be compensated or not for this knowledge they have taken from the community. If so, what constitutes just compensation? And what about the plant and other organism to which the knowledge applies? Who owns the biological resources? Now, as far as after the CBD came into being, that Convention on Biodiversity, the biological resource belongs to the country of origin. And if a company patents a gene or a chemical substance in plant, do they own it? So these are the questions to be answered. And as I was telling you, in USPTO you can see so many references on the Indian medicinal plants. So it amounts to be biopiracy, the theft of the genetic resources and the indigenous knowledge. and for various purposes they are using. And developed nations have long used these genetic resources available with the developing country. And many of these discoveries have been based on indigenous knowledge. And historically, developed nations have made little effort to acknowledge these genetic and biological resources that are property of the countries where they are collected. And the role of the indigenous people as only as stewards. So little or no effort have been made to compensate, and the result is biopiracy, and species disappear more rapidly and the biodiversity is eroded. At this time, the host countries and indigenous people want their contribution to be acknowledged and just compensated, and the free ride is over. So property rights and biotic resources concerned, a double standard currently applies to the ownership of genetic and biochemical resources. Unimproved genetic material is treated as ownerless. When you add value, it becomes, you can go for the patenting. And patents, trade secret, and plant breeders' rights apply to ownership of new varieties of plants, animals, and developed by breeders, and new chemicals isolated by the pharmaceutical company. Also, you can get patents. So the bioprospectors seek to discover and claim property rights over wild resources with a potential commercial value, and this squarely in the middle of the existing IPR framework. Can and should IPR protection to be applied to the wild genetic resources? So coming to the IP, what are the positive aspects of this IP? In the absence of IPR protection, there is no incentive for biotech pharma industry to develop new medicines. In fact, for developing a medicine, the companies are enormous amount is spent for that. So without the patent right, nobody will develop a new drug. So that is one of the aspects, and potentially the losses of all humanity, including the indigenous people, because needed products are never developed. And there is less incentive to preserve biodiversity and slow the decimation of the species, its economic value is low. So these are the positive aspects, and there are negative aspects like the IPR protection is granted. A few multinational companies will control the world's genetic resources. This is happening in many cases, and potentially the farmers and indigenous people could be prohibited from using their resources. And similar questions are now being raised in many other aspects also. So how can something not invented be patented? You can say that this indigenous already belongs to the community. How you can patent the knowledge arising from such things? And internationally, the standards vary widely. And US grants patent on novel DNA, genes, plant parts, plant and animal varieties, and biotechnical processes. And Europe has been much more reluctant in this aspect. They are conservative in this aspect, and genes can be usually be patented only if it is used in species in which did not evolve or could not have been transferred through breeding. And drugs or chemical compounds have been protected by patents in many industrial countries for decades, but not everywhere. So one of the classical example of a wrong patent is this turmeric patent. Some of you maybe know the story that in 1995, the University of Mississippi filed a patent on turmeric. And this has been challenged by the CSIR under the leadership of Dr. R. Mashelkar, then DG of CSIR. And this CSIR could win this case. And this is a classical example of how we can win the win over the USPTO wrong patent, but we spend a lot of money to win that patent, and every patent you cannot challenge like this, so it involves a lot of resources. So here I would like to show that patent, the details of that patent, you can see here. Then, so as I was telling you in my presentation, that a lot of criticism is there on IP, that there are limits that we should not cross. And the patent blockings and the anti-commons problem are notable in hindering the access to breeding material. And states have to ensure that protection of patent holders or plant breeders' rights does not discourage innovation. And always the IP fosters innovation. So there is a unbridgeable contradiction in the criticism and the price on IP. So there are beneficial uses and beneficial effects, and there are problem areas, and there are problematic effects on this IP. So another aspect is this access and benefit sharing. Now After the CBD came into being, from 1994 onwards, the genetic resources of each country is a sovereign, they have the sovereign right over the genetic resources. So each country is having its own law to access its resources. So this is very important as far as the use of these genetic resources are concerned. Ownership and sovereign rights on biodiversity. Again, the question, who owns the resources? As far as the CBD is concerned, each country owns the resources. See, to use any resources, we should have the prior informed consent of the society. That is for the principle and practice. And that should be based on the mutually agreed terms, and we should work on it, and we should have this material transfer agreement to use those resources. See, the access and benefit sharing will be based on this aspect. You should pay the access fee. It may be on upfront payment or milestone payment, sharing of royalties, etc., etc. And it can be on non-monetary benefits also, sharing the R&D results, collaboration, participation, then similar ways. So other issues concerned with access and benefit sharing are the conservation of biodiversity, sustainable use of these genetic resources, and uncertainties and opportunistic behaviors, and capacity building and biodiversity engineering. All these are concerned with this access and benefit sharing. And the other issues, again, it comes the IPR, then traditional rights of the indigenous communities, and bioethics and biosafety. So in many cases, entry access fee is charged, and collection fee is charged in some cases, and processing fee, then royalty on the final product. A classic case of this accession benefit sharing is the classical example is the Kani model developed by the Tropical Botanic Garden and Research Institute situated in Trivandrum, Kerala. There, under the leadership of Dr. P. Pushpangan, then director of TBJRI, he developed this model, and it was acclaimed one of the best model for the benefit sharing. The 5% of the royalty is shared with the Kani tribals, from where this information or the knowledge is taken, and developed a product called Jeevani from the medicinal plant Trichopus silanicus travancoricus. So again, just have more information on ABS. It refers to the way in which genetic resource may be accessed. And how does ABS works? It based on the prior informed consent and the mutually agreed terms. This we have to work out with each community. And what is prior informed consent is the permission given by the competent national authority of a provider of country to use or prior accessing genetic resources in line with the appropriate national and legal institutional framework. And what are mutually agreed terms? An agreement reached between the providers of genetic resources and users on conditions of access and use, and the benefits to be shared between both parties. So these are the themes of the access and benefit sharing. First is the conservation, then the commercial or non-commercial use, and the benefit will be monetary or non-monetary ways. So in short, safeguarding the IPRs of indigenous communities can be done by this benefit sharing model. First you survey, then prepare the database, then access to the database, then negotiation and signing of agreements, development of marketable products, and commercialization of the product, and from the commercialization, the benefit sharing with the indigenous and the local communities. So another interesting aspect is the TKDL. It is developed by Ayush and CSIR of Government of India. They digitize the entire information available in the traditional knowledge and from different texts. And now this is made available with the different patent offices of the world in 5 UN languages. And now the USPTO, Japan Patent Office, and the European Patent Office, they search this patent database before giving any patent. This way they prevent the biopiracy of traditional knowledge. So these are the different IP agreements in the world now. This is Paris Convention, that is for patent. Then UPO for plant varieties. Then International Undertaking on Plant Genetic Resources, that is on plant genetic resources. This is administered by the FAO. Then Convention on Biodiversity, that is mostly for the conservation of genetic resources and access and benefit sharing.
Rajshekar, can you summarize?
Yeah. Then TRIPS and the International Treaty on Plant Genetic Resource. So India government has already come out with a Biodiversity Act. This is restricting and allowing the use of the genetic resources. And this is working in three-tier way, that is national, state, and the local listing. And another law is the protection of plant varieties and farmers' rights. This gives the opportunity to register the varieties bred in different plants. And as I was telling you in the beginning, we have a lot of strength in the genetic resources. We have a lot of habitat diversity and a lot of medicinal plants. So the appropriate procedure for IPR protection benefit sharing gives the Article 3J of the CBD, then the National Biological Diversity Act, then the Patent Act and the Plant Variety Protection. These are the main laws concerning with the IPR in India, and all these are now in the national domain. And the documentation, the destination of TK, that's very important. Then the TKDL, which I was showing you, and the value addition of TK indigenous medicinal plants. And these are the issues of the benefit sharing, the size of the benefits, then cost of the benefit. And to conclude, what is the summary which I would like to say to you is the medicinal plants and related traditional knowledge. We have to protect it using IPR. Then sometimes it is geographical indication, trade secret, copyright, trademarks, and these are all, there are some sui generis system we should develop. And if you add the value, then the economic prosperity comes. So there are problems and solutions and prospects. The solutions are, the customary laws are becoming weak, and we have the national legislation which came into being, and now the country is having this laws. Then we have the international organizations and acts like WIPO, that is World Intellectual Property Organizations, then the Convention on Biodiversity, WTO, and UNCTAD. So this regulates the bioprospecting, value addition, and economic prosperity. So the WTO gives a lot of challenges and opportunities, and we should never give up. Thank you for your patient listening.
Thank you very much, Rajshekar, for the excellent review on IP rights. In view of the constraints in time, we will not have questions. We will discuss this at lunchtime and coffee break. And now I request Dr. Wahid to present these certificates. First to Shiv Prasad.
May we have a round of applause, please? I would further request Dr.
Next certificate, Rajeshekaran.
Next, I would like to invite Dr. Sharik Zafar from Holistic Healthcare and Research Organization, India. And the title of his study is Importance of Cupping Therapy in the Current Health Scenario.
Good afternoon. my senior colleagues, my friends, some of the young dear students. As you know, this is a very interesting topic, and there are a lot of confusions regarding cupping therapy. But it's an international therapy, and it's there in Chinese medicine, it's there in Unani medicine, and there is a lot of long history of this cupping therapy. So if we see it holistically, we have to understand the things, what are the key concepts, what is the mechanism of action, and how we can apply it clinically as we are doing personally it in Mumbai. It's a very vast concept. I cannot summarize the things in within 15 minutes, but I am just taking some of the glimpses of some of the main things of cupping therapy, just to make you understand what it is and what are the mechanisms behind its clinical therapeutics applications. This is hijama. Hijama is an Arabic word for cupping that is used for sucking of blood from some particular region or particular points of the body. I will not describe in detail. That is a long procedure, and there is a long history of different countries like China, Vietnam, European countries, Greece, Mexico, Russia, Arab countries. There is a long history from the Egypt, and it is well known there since 3,500 years, even described in Eber's papyrus, you can see. And they used in many disorders, and they just forwarded this therapy to ancient Greeks. Greeks taken this knowledge from Egypt. So there are, I have seen mainly two routes actually. One is Egypt, one is from China, the most ancient ones. So whatever you have seen in the Arabic countries, that has come from the Egypt to Greece, Greek to Roman, and then to Arabic route. Because as far as its use in Islamic world is concerned, it has come in the later period. Greece and Rome, Hippocrates, Galen, and some other Greek physicians, they use this cupping therapy. They were great advocate of this. Herodotus, he has written too much on cupping therapy regarding its mode of action, regarding lessening inflammation, regarding pains, regarding many diseases, regarding opening blockages. So you can see in 413 BC, this all explanations which we find in our modern literature regarding cupping, this all was there at that time. So it has a very long history of its mechanism of action. You can see the Galen cupping, doing cupping of a child. He is doing a dry cupping procedure. You can see other picture of ancient Arabic hijama. Hijama is also a prophetic medicine. There is a long history of its use by Hazrat Ibrahim alayhi salam, Musa alayhi salam, Dawood and Sulaiman alayhi salam, and in the later period, Prophet Muhammad, he has promoted this therapy in the Arab countries, and it's a Sunnah therapy. And you can see he has said that indeed the best of remedies you have is cupping. This is a hadith, and it's very popular in Arabic countries now. You can see these are the previous forms. In the ancient period, it was applied by the animals of horns, animal horns, then bamboos, then some pottery, clays, metals. Then these acrylic cups are there. Now these are new forms available, silicone cups, acrylic cups. There are pumps available. Main purpose is to create vacuum, just to make dry or wet cupping. It was used in later surgery also. You can see there are equipments made in the center for punch, for making multiple punch at one side. But as it is now, we have to take care of all the sterilized norms, so we cannot repeat one punch for another patient. So accordingly, everything should be separate, and the cupping should be done in a hygienic way. This is generalist and understanding of the dry and wet cupping. Generally people ask what is dry, what is wet cupping. So dry cupping procedure, just to create a vacuum on a particular point. We select according to the disease. In some disease we recommend dry cupping, in some disease we recommend wet cupping, and sometime dry and wet cups simultaneously also. In China they follow mostly dry cupping procedure. In Arab countries they follow mostly wet procedures. But as far as the holistic approach of this therapy is concerned, we should use both the procedure in combination as far as their mechanism of action is concerned in different disorder. And that we have to assess. We have to assess the misage or temperament of the individual. We have to assess the disease condition. We have to take a whole medical history, and accordingly we have to decide which system is affected, where is the pathological process, and then we select dry or wet procedure. You can see these are the ancient and modern procedures. You can see the horns, you can see the bamboos are there, fire cupping is also there. Fire cupping is also just to create the vacuum. But when the vacuum pumps are available, there is no need to do fire cupping. It becomes sometimes risky, sometimes it may create burn also if the glass is too hot. These are wrong cupping procedure. I condemn these procedures. Generally, it is followed by some persons there. They do long cuts. Long cuts are not required at all. That is condemned. Only hijama bishurt, that is pricking only, pricking. Only we have to do pricking with a surgical blade. That may be 11 number, 12 number, but not the long cuts. This is a wrong procedure. In that you may cut veins also, you may cut nerves also sometime. There are different regions of the body, and there is no need to apply these large number of cups irrationally. There is no relation with the disease generally, just they apply blindly on some surface. So that is an unscientific way. You see, this is the misage, relation of misage with cupping. As far as the relation of misage or temperament is concerned, in Unani system of medicine, these are of 4 types: Damvi, Balgami, Safravi, Saudavi, sanguine, phlegmatic, choleritic, and melancholic. These are 4 types of humoral classification in Unani system of medicine, and the application of cupping differs in different type of misage. As far as there are parameters for assessment of misage, I will not explain whole of the thing. This is just only one sample like that. You can see malmus or tactile sensation of the skin in sanguine or Damvi individual. It is warm, smooth, soft. So the character of skin, a reaction of skin is different in different individuals. So we have to maintain the pressure of cups. Accordingly, we cannot do same pressure in different type of misage individuals. In one individual, it may create lot of discomfort and pain. In another individual, it may create a normal hypervascularization reaction. So we have to select the therapy according to the musculature, according to the skin, according to the skin character, according to the physical characteristic, a characteristic of the skin, texture of the skin. That is very important. And accordingly, we will select the cupping therapy procedure in different disease, in different type of temperaments. As far as life force is concerned, this is very important aspect. Generally, people do not consider this aspect when they do cupping. They only see that we have to just clear the toxins out of the body. That is not the concept. Clearing toxins may be from some points, maybe from some particular pathological processes, but as far as the general action is concerned, it is through Ruh, or it is through Pran, or it is through Chi or Ki, that is called in Chinese system of medicine. So if you compare, these are the parallel words in these 3 major systems of the world, and accordingly when we do cupping, there are actions on the life force or Pran or Chi or Ki, you can see, and accordingly there are magical action. I tell you one of the case I have treated in Hyderabad day before yesterday. he was having a severe burn of in just his feet, his leg, and 4 months he was admitted in the hospital, and his skin is just shrinked. There was some inflammation also, and accordingly he was having the fixation, just his feet was fixed and he was not able to move his feet like this. So this movement was restricted. So I have applied only dry cups to some particular points on the back and upper portion of the thigh. And after doing half an hour therapy, his feet was immediately movable. So it gives instant results, In some chronic ailments, you have to give cupping therapy for 2-3 months also, but sometimes it gives instant results. As far as the theory of Ruhr or Pran or Chi is concerned, if you see it scientifically, there is a living matrix in the body in which biophotons are transferred. Biophoton is the minimum quantity of light. So our body emits light. Light is there outside of our body also, that is under invisible spectrum. And light is also transferring from one cell to another cell also, and this light is controlling the physiological functions of the body. There are scientific explanation of this also. So these biophoton transfer in through different meridian points also, through different channels also. So this is the spiritual anatomy of the body, popularly known as meridian system, followed by Chinese. And this concept was there in Unani also, but is still not so much explained in this modern literature of Unani medicine. Those were called as Masalik-e Ruh. As Ibnul Qaf of 8th century, he has described a whole chapter of Taskeen-e Alam, means treatment of pain, and he has given that if you block the Masalik-e Ruh, if you block the pathway of Ruh, you can suppress the pain immediately. So this, by doing the cupping, we can do that type of mechanism of action also, and we can suppress the pain immediately. So this is the spiritual anatomy. So we are following both the concepts holistically from Arab side, Egyptian side, and from Chinese side while we are doing the cupping therapy. This is regarding the Masalik Ruh. I will not go into the detail. As far as this key modification is concerned, it is clear that cupping relieves stagnation of key or blockages of key channels, energy channels, and by that it improves the many functions of the organs, and it removes different diseases. You can see there is a concept of toning and sedating. I am giving only the glimpses of the mechanism of action. Toning means toning of the energy, enhancing the energy. When the heat is suppressed or energy is suppressed, we have to give dry cupping for as a toning or enhancing the heat. While when the heat is exaggerated, we have to give wet cupping to suppress that particular normal pathological heat. And that will suppress that heat and the patient will get relief. Like in Pitta disorders or Safrawi disorders, we can give mostly wet cupping. So it depends upon the organs also. Some organs are hot, some organs are cold also. So accordingly the treatment is given and the relief is there. We have seen tremendous relief in painful conditions, tremendous relief in psychosomatic disorders also, like cases of depression, severe depression, taking 6 antidepressant morning, evening, they got relieved, and now they have overcome from that particular depression after 2-3 month treatment. So the concept of toning and sedating, then concept of Ruh, concept of winds. In Unani system of medicine, this concept is considered as Ri or Bad, Ri in Arabic, Bad in Persian, and in Ayurveda, they call it as a Vata. So we have practically seen that when we apply wet cup, the air comes in the form of bubbles from the blood. That is not from outside of the cup, because it has already created the vacuum and it is applied on the smooth surface. But the gas bubbles comes out of the, particularly from those points, particularly where there are inflammations, where there are pains, particularly in the painful conditions, we see this bubbles coming from this wet cupping, and pain goes immediately. If you say it scientifically, it has been correlated with the nitric oxide gas also. That is a neurotransmitter, you know, that is a vasodilating action on heart also. That has some positive actions also, but nitric oxide has some negative actions also, like it damages cartilages if in excess, it damages nerves also, it creates apoptosis of the pancreatic cells also, which create diabetes. So it is also a form of vata or wind. So it has been correlated with vata in some scientific literature. You see, the forehumoral concept, generally when you apply wet cup, you see the red blood is coming, and you are not able to see whether it is dark red, whether it is, but when you compare the cases, these are our personal cases of our clinic. So you can see the first one is having the Damvi character, that is a sanguine character, bright cherry red color of the blood. In the second cup, you can see the lower one is having some whitish portion, that is a phlegmatic dominance or bulgum dominance. In the third cup, you can see the blackish color of the blood, that is dominance of sauda or black bile. And in the fourth one, you can see the yellowish shade, that is due to pitta or due to saffravi dominance in the blood. So this forehumoral concept is also there, and we treat the patients, and we see even some cases are diagnosed also while we do cupping. Further diagnosis, sometime we do some further diagnosis also. It gives us indications of diagnosis also. It disperses pathogenic heat, generally through wet cupping. Then this is also a very important spiritual aspect as far as the touch and healer's touch to the patient is concerned. Because when we are doing cupping, we are touching the body of the patient, and accordingly our electromagnetic energy is interacting with the electromagnetic energy of the client. So that is why the effect of different healer is different. Sometimes patients say, "Sir, I have to do cupping with you only, not with your therapist." So this is their feeling, because they feel sometimes comfortable. If our intention is good, our spirituality is good, the relief is good accordingly by the grace of Allah, because overall the cure is from Allah or God only. We are only the little mean of treatment. So this is the spiritual aspect of the therapy that we follow in our therapies, and there is tremendous relief. As far as organ reflexes and cupping are concerned, this is also one of the very important aspect. This is very different from the Chinese concept of meridians, because there are neurogenic reflexes of different organs also. There are layers of tissues which are conducting these organ reflexes, particularly the connective tissue layers. You can see dermatome. Generally, this concept is followed by physiotherapists also. Crosswise segmentation of the body. There are organ reflex zones also. So when we apply cups on different part of the body, we see the results. Generally, these reflex zone, like some reflex zone may be in the feet also, and that is connecting to the back, or back is connecting to the feet. So depending upon the neural conditions, and accordingly the nervous system sharing conditions, there are zones. Like these are some of the examples.
Dr.
You can see
Safar,
the colors.
Can you summarize?
Okay, sir. Okay, sir. Sure. So when we apply cup on the back, it may relieve the feet pain also through that particular organ reflex zone. These zones are connected to the internal organs also. So, and it clears the lymphatic channels also. This therapy clears the lymphatic channels also, and you can see the sentence is there, when energy flows, the illness goes. There are lot of clinical results related to this energy we see in our patients. This is massage cupping that gives a different type of result. You can see these are different skin reactions of different cupping. These are only skin reactions in when we do only dry cupping, and accordingly their actions are there, like if it is less red, that is healthy blood circulation. There may be severe stagnation if it is black. There may be some original blisters also. If you can see, this is a dry cupping case, you can see the blisters. Generally we see the persons who eat prawns and all these fish foods and this seafoods, they have this type of reaction, blisters, only in, while we do the dry cupping. But that may be on a particular part also. Sometime it may be black also. Sometime you can see in the second lower slide, you can see the fat droplets coming from the skin. And the cholesterol was very high, although the patient was very lean and thin, but his cholesterol was very high. So you can see the droplets were also coming. These are some of our psychosomatic cases and depression cases, psychosomatic cases. You can see, although we can apply the head points with hair also, we have vacuum machines, we can do head cupping also. There are different points on the heads also. There are different patients. He is my Hyderabad patient. His wrist was not moving, and accordingly when we applied 2-3 cups, immediately after that he was able to move his wrist. He is a pilot. You can see the gas coming from the knee region, bubbles, gas bubbles, and his pain was relieved. He is an old 75-year patient. He has come from Los Angeles to Mumbai, and he was not able to offer his namaz or prayer normally. He was sitting on chair and offering the prayer, and after doing only 1 day dry cupping, he was able to move. He was, after 13 years, for the first time, he was able to move normally, normally offering prayer, normally doing ruku and sujood. Okay, thank you very much. These were some glimpses. We give training also. We are conducting one training in the month of January. Whoever is interested, they can come. Because I take just 1 day, 2 day long sessions actually, disease wise, point wise. So if anybody is interested, they can contact me. Any question, please?
Thank you very much, sir. And we will skip the question. I request Dr. Wahid to present the certificate.
Thank you, Dr. Zafar. It was indeed informative. Our next speaker is Dr. Ghazala Mullah from ZVM Unani Medical College, India, and the topic of our study is Unani formulation G1 in the management of obesity, animal trials.
Good afternoon, everyone. First of all, I would like to thank the organizer for giving me an opportunity to present my study over here, and my regards to the chairman and the co-chairman and the knowledgeable audience. So my topic is about Unani formulation G1 in the management of dyslipidemia and animal clinical trial. Now, a lot has been discussed last 2 days about the efficacy and the safety of the herbal medicine. So we have formulated a compound formulation G1, and we have seen the efficacy, and we have studied the toxicity and the safety data about the animal trial. So what was the rationale of about our study? We have seen that the WHO have estimated that there is a higher prevalence of overweight in 1.7 billion people, and by 2015 approximately 2 to 13 billion adults will be overweight and more than 700 million will be obese by 2015. 5% of the Indian population falls in morbid obese category, and it is increasing due to the lifestyle modification of Indian population. Now, the obesity, it also accounts for 20% to 7% of the total healthcare cost of the Indian economy. And the obese persons are prone to the various types of disorders like high blood pressure, high cholesterol, and high triglycerides level, and heart disease, type 2 diabetes, obstructive sleep apnea, etc. Diet, exercise, and lifestyle modification is required to deal with these obesity complications. And most of the time the persons are taking anti-obesity drugs and the drugs statins to get rid of the dyslipidemia. And these statins, mainly the atorvastatins, have side effects like diarrhea, vomiting, dizziness, etc. when they are taken in a long course. So we have formulated a Unani herbal formulation, and we have conducted an animal trial to see the effect of the G1 in dyslipidemia cases. So the objective of our study was in human being to assess distribution of fat in the body at weekly interval and to assess dyslipidemia and we have done the 4 weekly lipid profile. So for this, to test the efficacy and the safety of our product, we have done a preclinical animal study, and the experimental animal study was conducted on atherosclerotic model albino rat at ISO certified organization. It is at Pune National Toxicological Center, and it has done by the KG Apte madam. The objective of the clinical animal study was to determine the effect of G1 on lipid profile in atherosclerosis induced albino rats, and the method used was drug discovery and evaluation pharmacological assay. The animal model used was rats. The protocol was approved by the Indian Animal Ethical Committee through RP 104 on December 24, 2010. And hypercholesterolemia was induced by daily administration of 1 ml per 100 gram body weight of cocktail, and the cocktail was made by 100 gram of cholesterol plus 30 gram of propylethiouracil plus 100 gram cholic acid in 1 liter of peanut, and this cocktail was given to the rats for 21 days. And hypercholesteremia was confirmed by the elevated levels of serum triglycerides and cholesterol. Here we have given the cocktail for 21 days oral administration to the rats, albino rats, and the efficacy of drug on lipid profile in the animal model was seen. So 24 Vista rats were selected, and they are divided into 4 groups containing 6 animals in each group. And we have formed the 4 groups. 1 group of normal control, 2nd group was disease control, in whom we have given daily oral administration of 1 ml per 100 gram of body weight of cocktail for 21 days. The 3rd group was standard drug atorvastatin was given. So we have given daily oral administration of 1 ml of 100 ml of cocktail for 21 days along with the standard drug, that is atorvastatin, and the standardization was made by 1 milligram per kg, which was equal to 10 milligram per day of human dose for 35 days. And the 4th group was the test drug G1 was given along with the cocktail for 35 days. The analysis was done. So weekly body weight and food consumption was seen in each group and in each animal rat, and there was no significant you can say change in the body weight, and it was statistically done by the statistician by one-way analysis of variance method, and clinical signs of toxicity was not observed in any of the animal. Mortality rate was seen 16.67%. So this one rat died during the study and during the feeding. So it may be because of the person who is feeding the rat because of the overfeeding. And then we have done the hematological study. So we have done the total hemogram, HB, PCV, MSCH, and the total WBC count, etc. So it was not significant. And the blood chemistry, the most important part of our study was to see the lipid profile. So the significant activity is seen in the lipid profile. organ weight, individual weight organ was compared with the normal control group and with that of the standard and the drug dose. And then there was no significant observation is seen in organ weight. And in the histopathological also study, no drug-related changes is seen. So the most important is here we have done the group mean changes in the total cholesterol. So here you can see we can compare the control group with the standard atorvastatin and with the Givon. So you can see there is a significant change in the control group in day you can say 28, and in standard drug when we are giving the atorvastatin and the Givon. So in the test group you can see 41.4%, and in day 21 it is 116, and in day 14 you can see it is 105. So we were wondering why there is an increase in the, you can say, lipid total cholesterol level when compared to day 14 and day 21. So the last line you can see it is 105 and 116. So it is observed that the atrial plaque, so the cholesterol which is causing the atherosclerotic plaque is moved from the capillary and it has come into the general circulation, and that is what is giving the higher value on day 21. Then we have done the group mean changes in the HDL cholesterol. So here also you can see with the standard atorvastatin and the test drug. So it is seen that it is on the higher level on the Givon test group. The third is the triglyceride level. Again, you can compare it with the day 7 of the standard atorvastatin, day 14 and day 21. And in the test group, that is when we are giving the Givon, and when we analyze it on 28 days, you can see the change and it is 106. So here you can see the histopathological changes. So the disease control group, you can see the granulation. So in the kidney region, there is a swelling of the Bowman's capsule. In the heart also you can say the deposition, and in the liver tissue. Whereas in the test drug, when the animals are sacrificed after the study of 35 days, you can see the normal structure, normal histological structure of the liver, kidney and the heart. So conclusion, the effect on lipid profile of the tested drug. So there was a statistical significant decrease in cholesterol and day 35 in the test drug group, increase in HDL, that is the good cholesterol, on day 21 and day 28 in test drug group, and decrease in triglycerides in test drug when compared with disease control group. So hence, we can conclude that Unani formulation Givon can be effective as anti-atherosclerotic, lipid lowering and safe for use. So to summarize, evidence from animal experiment is strong and encouraging in favor of Givon, a Unani herbal formulation in correcting dyslipidemia. Hence, a statistically designed clinical trial will be planned on human subject after ethical consideration about the effect of Givon on human participants, also side effects if any, acceptability of the drug and cost of treatment etc. will be assessed. The human clinical study will provide scientific validated Unani herbal formulation for dyslipidemia. It will also provide strategies for developing scientifically validated solution in the field of preventive, curative and restorative medicine, especially for dyslipidemia and also for diseases associated with dyslipidemia. Here, this is our center at Pune, where we carried all the regimenal therapies of Unani system of medicine, and these are our contact number. Thank you.
Thank you very much for demonstrating that such clinical studies could be done with Unani preparations, and I hope the other groups of medicine like Siddha and Ayurveda also follow this type of a clinical evaluation, whether it is animal model or human model. Thank you very much, and now I will request Dr. Wahid to present the certificate. After this, we will have a lunch break, and after lunch break, Dr. Wahid will continue to chair the session. Thank you very much.
Thank you so much, sir.
As Dr. Rao said, we are now proceeding for lunch. We have
Good afternoon. I'm Dr. Jamuna from Bangalore. Today my topic is medicinal aromatherapy. It's a form of a herbal medicine utilizing the therapeutic grade plant essential oil to facilitate health and healing. It's a natural way to relieve stress, balance hormones, and to alleviate the symptoms or promote the healing for many illnesses without the side effect of synthetic drugs to treat physically, emotionally, and mental disorders. Essential oils are pure, natural elements derived from plant life. Essential oils can also be used to bring the body into balance so that it can heal more quickly, often without the side effects of pharmaceuticals. While the essential oils are effective on their own, they can also work in collaboration with the conventional medicines. A French cosmetics chemist named René Maurice Gattefossé, who was working in a laboratory, so he got burnt. So immediately he has plunged his arm into the vat containing a liquid. For his thing, he was immersed the arms into a lavender oil vat. Surprisingly, the burning quickly decreased and then stopped within a few moments. So over a period of time, with the continual application of a lavender oil, the burn healed completely without a trace of scars. He coined the term aromatherapy. Essential oils are volatile, natural substance. They actually immune system of a plant from which they are extracted. Essential oil has antiseptic, antibiotic, antiviral, anti-inflammatory. So they have terpenes. So terpenes are classified according to the number of units called isoprene units, monoterpenes, diterpenes, tri- and sesquiterpenes. So this is a system where it can be used in a wide range of a method. It should be practiced by a medical doctor or a clinical therapist or a qualified medicinal herbalist. This is the approach of 20th century. As I said, it was been founded by René Maurice Gattefossé. So medicinal aromatherapy is a form of herbal medicine utilizing to relieve the stress and balance the hormone. So subdivided into acyclic and cyclic, Otto Wallach in 1887 suggested the skeletal structure of all natural occurring terpenoids are built of isoprene units. To get 1 drop of oil, you may require to distill 100 grams of a plant material. Dr. Walnut had a student who did their internship, were responsible for the expanding his work, Dr. Paul Bellich and Dr. Jean-Claude Leprez. So they discovered that this has antiviral, antifungal, and antiseptic properties as well as being a powerful oxygenator, with the ability to act as carrying agent in the delivering in the nutrients into the cell of a body. According to the ancient Vedic science, in our Ayurveda, the typical mode of its usage were using the incense, other methods of inhaling or fumigation. Also, like Ayurvedic incense, use of incense in Ayurveda. The art of cosmetic and perfume making is one of the oldest in world. Since Vedic period, aroma and aromatic water of herbs, plants, seeds, spices, and flowers have been prepared and used by ancient physicians. There are Rishi Munis for curing various elements, creating proper atmosphere for meditation and other purpose. So we have Triyanka Patana Yantra that leads to the alembic portion of a brain. They trigger the release of neurotransmitters. They affect our brain and mental states of individual in variety of a way. Further, a stimuli transmitted to a limbic system cannot be consciously blocked, and all the olfactory therefore influence our emotions. So let us see how they blend an oil. Essential oils are highly concentrated and must be diluted with the vegetable oil. So 3 to 4 drops of an essential oil should be blended with 5 ml of a carrier oil based on according to their skin, according to their ethics of a body. So this can be practiced according to the English, French, and German. Some of the benefits of medicinal aromatherapy help in relieving the pain from chronic illness, dries up the cold sores, singles so fastly, heals wound, burns and bruises quickly, relieves PMS and menstrual syndrome, relieves pain from endometriosis, soothes muscle ache and pains, clears yeast infection, ringworms and athlete foot, assists digestive disorders, eases the depression and anxiety, calms the nerves and promotes sleep, reduces headache and migraine. So methods of using the oil. This can be used like vaporization, steam inhalation, cotton plug, and the mud pack, in which I practice in my clinic. The mud pack is supposed to calm down the sense and rejuvenate the body and mind. It also acts as a secret for the youthful skin with no wrinkles. The mud retains the moisture of a body intact, open the pores of a skin to let it breathe, relieve internal congestion and pain, and promotes elimination of morbid matters. Very fine nerve fiber in the outer skin also get activated, thereby stimulating the entire nervous system. The abrasive drying action of a mud over the skin helps in cleaning and invigorating effect of mud bath. A significant increase in the temperature is noted in the gap between the skin and the mud mask, as a thermal mud generates a heat on drying up, with the subsequent vast dilation of a microcirculation underneath the skin required more blood. This thermal mud even lends itself to the vegetal value of the oils and the essence that amplifies the therapeutic effect other than the attest potency in the osteoarticular field, for an instance in the case of venous insufficiency, stress, exhaustion or debility. These are the types of burners, types of nebulizers, the powers of essential oil. Combining both the individual chemical component found in the essential oil and number of different essential oil produce varying therapeutic effect, also known as synergetic effect. Knowing the chemistry of the individual chemical component of an essential oil and the general properties which the process help in using the essential oil both effectively and safely. Increasingly, medicinal aromatherapy has been used as integrated multidisciplinary approach to pain management. This is a therapy thought to enhance the parasympathetic response through the effect of touch and smell, encouraging the relaxation at the deep level. Relaxation has been shown to alter the perception of pain. Even if one ignores the possibility, the essential oil have pharmacologically active ingredients or the potential pharmacokinetics potentiation of conventional drugs by essential oil. Medicinal aromatherapy might possibly play a role of a management of a chronic pain through relaxation, stress management. The therapeutic action of an essential oil preserves the body's natural balance because of the chemical complexity. Essential oil don't disturb the body's natural balance or hemostatic. If one constitute exert too strong an effect in one direction, another constitute may block or counteract it. For example, certain aromatic molecule in the oil may vary stimulating both psychologically and physically, but the same oil may also contain the constituents that are calming and sedating, helps to overcome the anxiety or hyperactivity. Because the oil are natural substance, they tend to go only where they are needed and provide only the action needed to help restore the body's natural balance. The same oil may have significantly different effect on one person from one application to the next depending on his or her needs at that moment. This quality of an essential oil makes aromatherapy very safe, incidentally makes choosing the right oil less problematic. In spite of their chemical complexity, essential oil don't disturb the body's natural balance or a hemostat. As if one constituent exerts too strong an effect in one direction, other constituent may block or counteract. Oil may be very stimulant, both psychologically and physically. But the same oil may also contain constituents that are calming and sedating, helping to overcome the anxiety or hyperactivity. So this can be treats the whole person, both mind and body. It's very helpful way to treat the stress-related problem that many of us seem to suffer now that over the life has become so presented and mechanical lifestyle. This is where I studied in my BSc Medicinal Botany. Thank you. And this is where I presented the poster presentation in Ayush, like Government of Karnataka. Thank you.
Would anyone like to ask any questions?
Madam, it was a very beautiful presentation. Right now, in the present scenario, we see that the stress is growing day by day to all the people. And often the people are having headaches at evening just because of the stress. So is there any aromatherapy? Stress causing headaches. Yeah. So is there any aromatherapy which... Okay. 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 It has to be put on the forehead?
Yes, it can be put on a forehead. If you're good at your acupuncture points, you can keep those oil in an acupuncture point.
Okay.
Okay, permitted test in your sensitive areas first, then you can apply. If you want, you can apply a neat oil, permitted it should be a branded one.
Okay.
Okay, you can apply, you can inhale rather than applying because I don't know which sort of a skin and what sort of allergic you are. You can inhale, sir.
Okay.
At least inhale for 5 minutes.
Okay.
And as anyone can practice meditation or pranayama and then keep inhaling, you'll be coming out of it.
Okay. Thank you.
In addition to that, insomnia is a condition where people are becoming, more and more getting with suffering with insomnia. So these aromatic therapy will help.
Yes, sir. We have to analyze the case. For insomnia, we cannot prescribe generally. We have to analyze the case. First, we have to take all the case history, and then, according to the
But anyway, irrespective of the cause, what are the things? The drugs you suggest for them for aromatherapy? Yeah. But it is produced where actually, for the knowledge of the audience, it's produced where these people can get this. No, but that is mostly adulterated. For example, as we were talking about the earlier question, responding to the earlier question, probably IIM, Indian Institute of Integrative Medicine, Jammu is cultivating at large and producing these oils. Probably with a general you can get it.
There are many, even in Karnataka and Bangalore, they are producing the sandalwood oil. Like we have MSIL, and even you will get a very good branded one. But permitted, you have to select a good branded one. Because similarly, the essential oil, you'll find 2 brands. If you smell, it will be varying. But you should be very good in analyzing those things. That is what 10 years of my service have come across. You should smell, you should see the effects of it. So then we can prescribe to our patients.
Okay. Any more questions, please? Then thank you very much. Dr. Jamuna, I request Dr. Irfan Saab to felicitate the speaker with certification.
Thank you, Dr. Jamuna. Next, I would like to invite Dr. Moin Bubair from Islamic Institute of Dawa and Dua, India, and the title of his study is Hijama, Cupping the World's Best Medicine.
Thank you very much. Thank you very much for inviting me here in international conference, to the OMICS groups, and to the chairperson and co-chairpersons. Again, we are switching on to the cupping, the world's best medicines, the best therapy. I am Dr. Moin Bubair from IIT India, Mumbai. I am a clinical practitioner. I am not a PG student, this thing. I am not a, any professor, this thing. I am just giving you the best clinical result why I observe in my clinic practice for the hijama. Hijama. Again, in brief, hijama is Arabic word, means sucking. Means you have to suck something. If you have the pain on the same target area, we are doing the sucking with the cups. And before it was by horn, by glass cupping, this thing. I'm not going in the detail. Already Dr. Sharik Zafar doing best way for me. Already explained the basic of the cupping. I'm just going for the clinical aspect now. So hijama in Arabic means sucking. Is the Arabic name in traditional medicine for wet cupping, where blood is drawn by the vacuum from a small skin incision for the therapeutic purpose. It is reported that the Islamic Prophet Muhammad said, indeed the best medicine of remedies you have is hijama. Hijama is Arabic word for the cupping. There is only wet cupping in Arabic means practicing there, and hijama means only wet cupping. Muhammad says there is a cure in the cuts. Means if you are doing the hijama, you have to make the cuts. There is no dry cupping in Islam. Okay, if you are doing the hijama, it is only cutting. You have to do the cuts, it is a hijama. If you are doing without cuts, it is the Chinese cupping. And if there was something excellent to be used as a remedies, then it is hijamas. The procedure, very brief. Hijama can perform almost everywhere on the body, often on the side of ache or pain, in order to erase and elevate it out. Here, we are doing the dry cupping on the back of the patient. These points are very, very nice point. It can detox whole body. I'm just putting the cups on the head, and this treat the cholesterol and BP patient and mental distribution patient in 2 or 4 sittings. Here again on this is the point for the addiction points. I'm just putting the addiction point. Any type of addiction will erase from these points. The first one is for the acne. In one sitting, unbelievable result. In one sitting, you can treat acne. In one sitting only, you can treat acne. It's a believable result. The second one is for the cholesterol. You can't believe without medicine, you can control the cholesterol level by this cupping means putting the cup on your heads. This is a nice point for the males. It is for the sexual incompetency. This thing. The fourth slide is for is a cancerous patient. I just put the cups on this neck, back of the neck, and one on the target point. And this patient is a very nice thing. Cancer Institute of Tata is rejected this patient. She can die in 1 month, but still is with after 6 months she is alive. The fifth point is for the thyroid, hypothyroidism or hyperthyroidism. You can treat from this point. The sixth point is for the this knee pain, knee joint pain, knee knee swelling. This thing you can go on from this point. This point for the slip disc problem, this thing, you can treat this thing from the these points. This is very nice point. You can boost your eyesight from these points. Do 2 or 3 times, your eyesight will improve with these points. This I put on the chin for this tobacco chewing patient and a lot of ulcers inside the mouth, and it's treated without medicine. It's 4 sessions only. This point was a sciatica patient, very nice point, and lower pain, that's nice. And this point for the mental disability patient, very nice result with this thing. I did after this wet, dry cupping, I did the wet cupping. Method of cupping is very easy. The location is first shave. If necessary to ensure a tight seal with the cup, the mouth of the cup, metal, glass and plastic cups are generally used. Although traditional horns were used, it's placed on the skin at the site chosen for the hijama. Then a tight seal is created. The traditional method is a burn a small piece of paper on cotton inside the vessel so that the mouth of the cup sinks to the skin. Some practitioners now use a machine instead of the manual cups. Some practitioners strictly adhere to the Prophet Muhammad method with the use of fire, both for the sterility and the benefit or property from the element of the itself may be present. The cuff is left to cling to the skin for a few minutes, then it lifted off and several very small incisions are made in the skin. The cup is then put back and it was before until the flow of blood subsides. Hijama is considered a form of energy medicine because it has been claimed to unclench the meridian of the body, and its views of some practitioners are cured that a relative black magic and possession also. The oldest record of hijama cupping in the Eber Priors in 300 BC. Oldest book on cupping is 1500 BC by the Egyptian. China started cupping in 1000 BC. Greece, Hippocrates in 400 BC. Islamic cupping hijama is started in the 500 AD when our Prophet came and they started out. Types of cupping is simple, you know it out, dry cupping and wet cupping. Dry cupping, we just put the cups, but it is a Chinese line of treatment, it's not an Islamic line of treatment, it is not hijama. It is cupping, but by China treatment. But in Islamic hijama, we are doing the wet cupping, and we are putting the cups, and after that, removing the cup after 10 minutes, and make the cut there. And after that, again, put the cup for 10 minutes, the blood come out in the these cups, and we just detoxificate in the body. The main purpose of the hijama is to detoxification of the body. If you putting the cup on the spinal cord, your whole spinal cord will be drained out. It's unbelievable results. If you put the cup on the heart, all heart element will clear it out. If you put the cup on the lungs, you can clear it for all the lung diseases. If you put the cup on the liver, you can clean the liver fully. If you put the cups on stomach, all the stomach element will wipe it out. If you put the cups on the kidney, both the kidney will wipe it out and detoxification out. All the kidney element will become normal. All the parameter will become the normals. Difference between the Chinese cupping, I already told it out. China are doing only the dry cupping, and hijama cupping is never dry. Case study by me in IDD and 5C. I make one council of hijama council, and I registered and trademark with the trademark department of India. The name is Council of Cupping and Cauterization Cure Centers. This is my institute, again second institute, Islamic Institute of Dawa in Dubai, is located in Bhiwandi, Mumbai area. And second council is in Dubai, and one office in Mumbai also. To study this thing, I just make some patient by my own way. I am not having the clinical data, I am not a PG practitioner, I am just doing the clinical trial in my own setup. To prove that hijama cupping, the 7 Sunna point, as I told you about, 1 cup on the spinal cord, second one in the heart, third one on the lungs, fourth one on the liver, fifth one on the stomach, and both 6 and 7 on the both kidney. This 7 Sunna point detox whole body and made it toxin free and cure all the major complicated illness. It's unbelievable result with this 7 point. You can put for any disease, this cups you will get the magical and miraculous results with this thing. Method. More than 90 kind of disease or symptoms were treated by cupping therapy in my practice. According to included study, the top 20 diseases condition in which cupping is commonly employed were pain, 300 study by me, herpes zoster, 91 study, cup and stomach, 70 study, acne, 92 studies, common cold, 210 studies, urticarian, 81 studies, lateral femoral neuritis, 61 study, facial paralysis, 13 study, cervical spondylosis, 90 studies, lumbar spine, spleen, 19 study, this mastitis, 14 study, ball net, 1 or 2 studies, headache, 13 study, soft tissue injury, 10 study, arthritis, 10 studies, and wound healing, 8 studies, sciatica, 7 studies, and 264 studies were conducted on the other disease treated by cupping therapy. And main results are, we found in all illness, cupping have miraculous results. Conclusion. Cupping have tendency to cure all major illness which are still untreatable with modern medicines. Overall results are all type of pain gone after hijama cupping, toothache, pain of cancer, earache, abdominal pain, menstrual pain, etc. in 1 session only. Varicose vein in 3 sessions. We are having the session of 1 week or 4 days gap, this thing, according to the patient needed. Slip disc, vertebral dislocation in 4 sessions. High cholesterol level in 2 sessions only. High sugar, high uric acid, serum bilirubin in 3 sessions. Cancer pain patient did not need morphine after the cupping. That is a very miraculous results. Brain hemorrhage patient, cardiac diseases and all lung diseases needed 4 sessions to cure. Thyroid, both hypo or hyperthyroidism, need only 3 sessions. Injection abscess drain without pain with the cupping. You just put the cup on the injection abscess area and make the pressure, everything will come out without, you have to do not give the pain to the patient and it's drain out without pain. Tennis elbow treated with is fully with cupping, that is a miracle. Psoriasis, eczema and other skin diseases needed 4 sessions. You have interval of 1 week, I think, this thing. Frozen shoulders, cervical spondylosis, lumbar spondylosis, hemiplegia needs 4 sessions. Alopecia in 4 sessions. Leukoderma in 4 sessions. Acne in 4 sessions. Allergic rhinitis in 4 sessions. Sinusitis and nasal polyps in 4 sessions. Eyesight boosting in 4 sessions with 1 week gap. Mental retardation, BP, sugar concentration loss, tension, thyroid, hormonal misbalance, gout, arthritis, and all untreatable ailments magically cure fully with the hijama in 4 sessions only. Conclusion. Overall conclusion is this. You cannot got all this benefit in a single medicine or therapy. So why not my words prove this nicely? Hijama cupping is the world's best medicine. Thank you.
Do we have any questions?
Good afternoon, sir.
Good afternoon. Assalamu alaikum.
Walaikum assalam. A very good presentation of hijama. I have been practicing hijama lately, but there are many questions which are in my head. Regarding hypo and hypothyroidism, the point which you have shown us below the chin, is that the only point needed to do hijama?
Yes, I am doing only one point only, and miraculously, I am having a study on the thyroid with 21 patients, and miraculous results are there with the thyroid patient, mean only 1 point on chin.
Definitely, sir. So does that depend upon the intensity of the disease of the patient? Does it vary patient to patient, or only 3 sessions for hyper and hypo?
Yeah, both. I am just reading with 1 point hyper and hypo both.
So kindly please can you elaborate on mode of action? I mean, hypo and hypothyroidism is relatively related to pituitary. So deficiency of producing hormones.
We need more research result on this thing. I just told you, I am just as a clinical man. I am just giving the clinical data. This thing means with 8, 9, this thyroid problem became 1 or 2 within 2 or 3 sessions. I am having a report of this thing. I am having means also having the if you want to see, I am having also video clips of patients. Lot of 2,500 clips are there with very less session for there to make it there. If you want to see, we can show it out to you. You already there? Clips? Okay, no problem.
Thank you, sir. Thank you so much.
One more question. Yeah, of course. Same. No, we just make the bald patient. Without bald is not possible. Yeah, you can make the bald. Near to varicose vein, we are putting the cups. Near to varicose vein, with the put the cups, and miracle results are there. Just try it out, no problem.
Sir, one question probably reflecting to the feminine gender who is present over here. You said the one sitting for acne vulgaris. One single sitting or 2 sittings for acne vulgaris.
Yeah, of course.
See, let me ask you the question. Listen to me first. See, there is a fair chance the people may definitely improve. Could it be a first, a second, or third immaterial for acne vulgaris? But there is a fair chance when you take the incision, some patient may have the susceptibility towards develop the keloids. See, if you develop the keloids over the face, probably that has a biggest cosmetic problem for them. So, what do you suggest with your experience?
I already treated more than 300 patients with the acne vulgaris. A lot of ladies guys are coming to me, and my wife is also doing the cuppings. We are giving together, doing very nicely result. And with this 300 patients, I didn't get any keloid. You have to make the good incision there, and you have to follow up the patient very well. And you have to tell the patient to come, and this incision will go with this betadine, this thing. You have to make the proper cleaning of the incision. It's never developed. In my case, it's no development with the keloids.
Excessive granulation tissue probably that people will have tendency to develop.
Yeah, more research needed by the people like you on hijama, this thing. With the documented results are needed. Documented presentation and this thing are needed. I am a clinical man. I tell you, I am not a PG in this thing. I just giving the clinical result while getting from my clinics.
How about these miracle results? What do you mean by these miracle results?
Miracle is a magical result. Yeah, of course.
The miracles have gone with the
Okay, no problem. It's a magical result. Okay.
Thank you, my dear.
Thank you, sir.
Anyone? Yeah.
Sir, we'll have questions later.
Okay, no problem.
Because we're running short
anybody
of
want
time.
to see this video clipping I am having here with my laptop? He can see with my. Thank you very much.
Thank you, Dr. Moin. May we congratulate Dr. Moin. Next, we have Dr. Arun Kumar from Mahavir Cancer Institute and Research Center, India.
It's great pleasure
for me to speak among all the august presence on this international conference. I'm thankful to the organizers, the OMICS Group, and especially the chairpersons and the co-chairpersons. Basically, my topic is on ashwagandha, which protects the arsenic-induced testicular toxicity in rats. Now, what was the purpose of doing such a research? The background, the rationale is, I would like to go some, Napoleon was the first person who was given the arsenic by this suspected man, and Napoleon died with that. Now, regarding the water, the oceans have 96.5%, the groundwater 30.1%, the lakes 20.1%. Now, what is the origin of arsenic crisis in Indian subcontinent? Switching from surface water to underground water, people used surface water until 1970s, and millions of tube wells were installed just to have the reduction of infant and child mortality, and thus poses severe due to the demand for the pathogen-free safe drinking water. Underground water became very widely popular, and problems arose due to arsenic contamination after that, and which affected almost the whole world, causing health-related problems. If you see the entire Asiatic countries, the red spots which are showing are arsenic-affected areas. And in India, if you see, the entire Gangetic Magna Belt is affected with this arsenic. This is the global threat. If we see about the Himalayan region, the Nepal, Tarai region especially, 19 districts are affected from the arsenic. If we see about the India in the northern region, the basically the Nainital Lake area is affected from the arsenic. Now, if we see this Gangetic belt, this is the major arsenic hotbed of India. And if you see the entire Gangetic belt, this is all contaminated with the arsenic in the underground water. If you say about the Bihar, in 2002, Bhojpur was the first district which was affected from the arsenic, and then after 16 districts in 2009 and till date have been reported to have contamination of arsenic in drinking water. Even the Kosi region, which is the sorrow of Bihar river, is having this problem. Now, the next world war will be over the water, and the groundwater is the major source of water in our country, with 85% of the population dependent, and groundwater table is declining 33 centimeters per year. Now, what are the sources arsenic affecting the human health? The drinking water, irrigation water, through the food chain, and burning of cow dung cakes. Now, what are the consequences of arsenicosis? It is causing health-related problems, especially dermatological, respiratory, gastrointestinal, cardiovascular, hepatic, neurological, hematological, renal, mutagenesis, reproductive, cancer, and mental health. So I will be dealing with the reproductive as arsenic having atomic number 33 with atomic mass 74.92. It is category A1 carcinogenic, readily soluble in water. Within the body and blood and organs, arsenate converts into dimethyl arsenic acid in the body. This was in the 2012 when we visited the first Bhojpur district, where Simaria Ojipatti was the most affected area. You can see the arsenicosis in the patients. In the child with the toxicity in teeth, toxicity in hand, toxicity in fingers, lesions in skin, toxicity in legs, swelling in stomach. Then it was a visit to Simri village of Buxar district. It is very near to Ganges, and we found most of the couples, especially 10 to 11% of the population, were having infertility problems. The most of the males were having 10 millions of sperms in their sperm counts per ml. These are the suffering villagers. And in most of the hand pumps we tested, the arsenic level was very high, up to 220 to 265 ppb, as the normal ranges of WHO is between 10 ppb, below 10 ppb. So finally, the people are suffering from infertility, skin irritation, gastritis, and flatulence, and the low immunity. This was the major problem which the people were suffering. So this gave an hypothesis to me that this arsenic is might be producing free radicals or lipid peroxidation or other free radicals, disturbing the reproductive physiology and metabolism, causing abnormal functioning like infertility. As in the present scenario, we cannot stop the flow of arsenic or other exogenous chemicals from entering into the food chain. Can there be some remedy for the target organs or suitable antidote? But at what extent it can be checked, it is a question mark. Can the use of medicinal plants be the answer? That we will have to check. And this initiated me to think over the major problem, that is the infertility. Although the entire world is busy in making filters which can filter the arsenic from contaminated water to arsenic-free water. But what about such a huge population? And what about the irrigation of the crops by the same water? Medicinal plants like ashwagandha can act as antidote against arsenic-induced poisoning was a novel idea and indeed a novel work ever done anywhere in the world. Ashwagandha, we know, that is Vattuone somnifera, as it belongs to the family Solanaceae and is an evergreen shrub grown wild and also cultivated for medicinal use in many parts of India to cure variety of diseases, including cancer. The major components are vitaferin A and vithanolides. The pharmacological actions are, it is a good fertility booster, known fertility booster, having rejuvenative effects, antioxidant properties, potential role in cancer therapy, immunity boosting herb, adaptogenic and anti-stress herb, cardiovascular and diabetic protection. So the materials and methods for the reproductive toxicity study was the Charles Foster animals chose for this study after the ethical approval from the Institutional Animal Ethics Committee. Proper caging, food and water was provided to the rats at labdom during the entire experimentation. Sodium arsenite was used as the chemical for the study. Grouping of the animals was done. And after estimation of LD value of sodium arsenite, the maximum tolerated dose was calculated at 8 mg per kg body weight. And Vattuone somnifera, that is ashwagandha, ethanolic root extract was prepared. And after LD50 estimation, the administration dose was calculated and finalized at the rate of 250 mg per kg body weight for rats. The sodium arsenite was treated to the animals for 8 weeks, and then after, with ashwagandha was given to the animals for 4 weeks per day. Parameters used for the reproductive study was sperm counts and sperm motility study. Sperm was collected from cod epididymis. Hormonal assay was done, especially the serum testosterone levels. Estimation of lipid peroxidation was done, and histopathological study of testis was also done. Statistical analysis was done through the ANOVA and the observations. We saw the sperm motility in arsenic treated as loss of sperm tails and coiling of the tails. The control had the values of 16.16%, while the arsenic treated showed 11.66%, and while ashwagandha treated showed 62.16%. The sperm counts in millions showed in control 5.6 millions per ml, while in arsenic treated it showed 0.73, while in ashwagandha it showed 4.1. The testosterone levels in control treated it showed 6.4 ng per ml, while in arsenic treated it showed 1.21, and in ashwagandha treated it showed 5.2. The lipid peroxidation levels in nanomoles per ml showed control 2.09, with arsenic treated showing 78.1, and ashwagandha treated showed 5.98. Now the histopathological study. We can see here the beautiful picture of testis showing all the spermatogenetic phases. The primary spermatocytes, spermatogonia, secondary spermatocytes, spermatids, and spermatozoa. Now you can see the arsenic-treated rat testis. The complete phases are not seen. That means something wrong is going what we are seeing in the infertile couples. Similar results we had seen in this. Now after ashwagandha treated, again there was rejuvenating or ameliorating effect. We can see all the stages of the spermatogenesis back. So results. Sodium arsenite causes decreased sperm motility, low sperm counts, low testosterone levels, increased lipid peroxidation levels, as well as testicular injury. But ashwagandha ameliorates by increasing sperm motility, increasing sperm counts, increasing testosterone levels, lowering lipid peroxidation levels, and finally normalizing the testicular injury. So to conclude, ashwagandha is the best antidote against arsenic-induced testicular injury. It can be one of the solutions to cure infertility for such a huge population. My acknowledgements to DSTSTP, New Delhi Government of India for granting me the project, and Mahavir Cancer Institute and Research Center, and my co-PI, especially Dr. Muhammad Ali and Dr. Ranjit Kumar, and my entire project team. Thank you. Yes, sir, please.
Nowadays, we have developed one device from magnetic water.
Yeah.
Will that help for that your project?
Yeah.
Device of the magnetic can pass the water from the magnetic device. Because they have tried all over the world. Because I am a healer, we also use some magnetic belts for health. Yeah. So I think myself, why should not we try for the water? So when I go in the waters and I find out all over the world people are using this device for the cleaning the water, make the soft water. Yeah. So this water will help you or not?
Yeah, Bill, that you are right, and that's why the government of Bihar have they are going to plant one of the they are taking Ganga water from the, they will be cleaning that and they will be providing that to the people. So that is the one solution which the government of Bihar is thinking. But the thing is that right now the people are suffering from that. So that solution will come after 2 or 3 years or 5 years. But what about the current scenario? That is the problem.
That's why I advise people. We have developed this device and we have tried it, and 30 to 35% grown in the agriculture field with the best quality of the agriculture.
Yeah, yeah.
And they can be used for the health also.
Yeah, yeah. We have plenty of water. We have plenty of surface water. That's we are right.
Thank you.
Yeah. Yeah.
I'm a pharmacologist over Central Research Institute of Unani Medicine.
Yeah.
So basically, I don't have a question, but a suggestion rather.
Yeah.
That you have used only one dose of Withania somnifera, 250 mg per kg. So for a scientific study, you should use.
No, we have done similar experiments, out of which we have titrated this dose as the one of the.
Okay, you didn't mention that. That's why I
didn't mention because.
Point. So for dose dependent activity,
no,
you should
that
have
I know.
at least
That I know.
Okay,
and
fine.
we have done plenty of work on this.
Fine, thank you.
Yes, ma'am.
Increasing number of the sperm
Basically, when arsenic was given for 8 weeks, after that the sacrifice was done and the sperm count was done after the chorda was taken after the incision of the chorda, it was done. And then after the same group which the arsenic was given, after giving this ashwagandha was again, sacrifice was done and then same test was done. So comparing that both of the same group, it was done and the results were taken.
So because the total duration of spermatogenesis is about 72 days.
Yeah,
so
yeah. No, for the rats it is 35 days.
days.
35 days it is.
Okay, thank you.
Okay.
Rats are faster than man.
Yes, sir, please. Yes, sir. Bilava.
No, sir. You can say botanical name. Yeah. That can be studied. I will take with you. Yes, sure. Thank you so much. Yeah.
So thank you very much for a nice talk.
Thank you, Dr. Arun. May I request the chair to facilitate Dr.
I request Dr. Mandal to give the certification of arts.
Our next speaker is Dr. Sheikh Nikhat from Regional Research Institute of Unani Medicine, India.
Respected chairpersons, dear colleagues and all friends, Assalamu alaikum and very good afternoon to all of you. Myself, Dr. Sheikh Nikhat, Research Officer from Chennai. My today's topic of presentation is efficacy of Unani regimen, that is hijama therapy, wet cupping therapy, with Unani formulation in the management of type 2 diabetes mellitus. I think you heard a lot about cupping therapy, so I'm not going to detail on that particular topic. Just an introduction of diabetes, a group of disease characterized by high level of blood glucose resulting from defect in insulin production, insulin action, or both. It has been affecting lives for thousands of years. It was recognized by Egyptians in manuscript dating 1550 BC. According to the National Medical Journal of India, ancient physicians were well aware of the conditions. Diabetes, which they called sweet urine disease, by determining if ant were attracting to person's urine. Different names in Unani system: dolab, salsul ball, that is excessive urine, zalakul kolya, dawara, that is a symptom repeated in cyclic order, and muatisha, that is excessive thirst producing. You know very well three major types: type 1, type 2, and gestational diabetes mellitus. Type 2 needed oral medication. Oral medication can alter insulin production or sensitivity. And I'm not going to detail. The risk factors are family history, obesity, physical activity, especially stress, race, and history of gestational diabetes, PCODs, hypertension, hyperlipidemia. The clinical features, that is 3 Ps: polyphagia, polydipsia, and polyuria. Blood vision, fatigue, paresthesia, skin infection, sudden weight changes, and vaginal itching. As you know, the diabetes is a very fulminant problem in today's era. That is a complication, stroke, micro and macro circulation, heart, that is a cardiomyopathy, kidneys, nephropathy, eyes, retinopathy, nerves having peripheral neuropathy, and skin dermatopathy. Investigation, these are the routine investigation: fasting, plasma glucose test, OGTT, and HbA1c, urine analysis for fasting, and PP sugar. The treatment regarding the diabetes mellitus, the oral medication, that is sulfonylurea, stimulate beta cells, bigonides, improves the insulin's ability to move glucose. Sulfonylurea and bigonides in combination we can give. Alpha glycidase inhibitors and meglitinides. These all are the oral medication which is now available in the market, and the insulin therapy also available in the market for treatment of diabetes mellitus type 2. Friends, in spite of this all treatment available in the market, still the diabetes is a very high caution in front of us, being an alternative system of medicine. So current scenario, if you see, India is being called the diabetic capital of the world. According to Diabetes Atlas, the global prevalence is estimated to be the 4.6, representing 151 million people, and is expected to go up to 330 million people by 2025. Recent, the global prevalence reacting up to 6.6%, representing 285 million people in 2012. Individual national prevalence rates over 1% to almost 31% have been reported. Currently, India has the highest number of diabetes patients. So there is a need of an alternative system of medicine which reduce the course of illness, increase the quality of life, and as an adjuvant therapy, here I use the hijama therapy. You heard about by Dr. Sharik Zafar, and Moin sir has explained a lot of it about hijama. As you know, the authenticity of hijama, the Messenger sallallahu alaihi wasallam said, indeed the best of remedies you have is the cupping therapy. So I use hijama here as an adjuvant therapy with oral Unani formulation. My study design, it is an open randomized clinical trial on 30 patients equally divided into two groups, Group A and Group B, and duration of study was 90 days. The follow-up was 15, 30, 45, 60, 75, 90 days of the study. Drug and doses. The drug is very common and it's in traditional medicine which is used for the treatment of diabetes, that is a sulforaphane. And jamun, sirka jamun 20 ml twice a day. With hijama therapy, it is given to the Group A, and Group B is treated with only oral Unani formulation, the fenugreek and black pepper. Selection of criteria, that is the inclusion criteria, 30 to 60 years of age, known case of diabetes mellitus type 2, both male and female included in the study. The fasting glucose level up to minimum 130 milligram, maximum to 160 milligram. And postprandial was 250 milligram, not more than 250 milligram, and with normal BT and CT and normal liver function, renal function, and other biochemical parameters. And patient especially willing to participate in this study. The exclusion criteria, type 1 diabetes, secondary diabetes mellitus, pregnancy, lactation, and complication, patient present with complications has been excluded, and systemic illness and overweight, more than 30 BMI, and abnormal BT-CT. The diagnosis was based on history, clinical presentation, and laboratory investigations. All the patients were informed about the nature of interventional procedure, drug, dose, and objective of the study. Informed consent was obtained from all the participants. The blood investigation at the baseline and at the end of the study or after the completion of the trial was the fasting blood sugar and PP, hemogram, HbA1c, RFT, LFT, lipid profile, urine analysis, and BT-CT. The withdrawal criteria, the serious adverse event and right of the trial, subject to withdraw the consent at any time during the course of the trial. If the patient or the participant not willing to continue the study, if the participant not regular or not interested in the therapy or non-compliance, at any acute systemic illness during the therapy or drug or therapy intolerance. Here I used 3 points for the hijama therapy. Especially, I combine hijama therapy with acupuncture point to have the good results. Here I use 6 steps to do the hijama therapy on diabetic patient. The first step, the selection of the diabetic point according to the acupuncture point, like D14 and B19. And step second, the mild section was created by disposable cups for 1 minute. And the third step, small longitudinal cuts made with the 11 number surgical blade under all the aseptic precautions. And the step 4, again strong suction was created on the same point. The skin lift upward, blood from the incision is allowed to flow freely, and it is stopped automatically. And the step 5th was the pressure is released after 3 to 4 minutes, and 6 was the blood was collected and the scar were cleaned properly. By observation, this is a demographic data, the maximum patients of 40 to 50 years of age, male and female included, and less patient between 51 to 60 years of age. According to diet, the 12 patient or maximum 40% patient was non-vegetarian and rest of that vegetable or mixed diet. According to Mizaj, had the Safrawi Mizaj patients were noted 14 patients, and followed by 30% patient of Damvi and 20% of Balgami, and single patient only noted by the Saudawi Mizaj. This is a chart showing the improvement, partial improvement or not improved symptomatically, polyphagia, polyuria, and numbness or burning and fatigue. And we saw the good result in Group A when we used hijama as an adjuvant therapy. Here, just an mean reduction in HbA1c. No doubt, it's not a significant changes in HbA1c, but it's noted more in Group A. Here, the significant result noted in BSL fasting, reduction in BSL fasting in Group A. You can say the p-value is 0.001. We can conclude that the oral Unani formulation, methi, that is a fenugreek, plus jamun, that is a black plum, and hijama or wet cupping therapy with particular point as an adjuvant therapy helps to combat the hyperglycemia. This study also validated the traditional use of non-pharmacological procedure for the treatment of diabetes mellitus. However, the large-scale and multicentric clinical trials are still required to establish the unfulness of this procedure. Such researches might help in finding new modules for the management of lifestyle disorders, including diabetes mellitus. These are some supportive authentic researches which showing the anti-diabetic property of fenugreek and black plum. These are authentic published journals are there. My acknowledgement, I am especially thanks to respected DG Saab, Dr. Shakir Jamil from Central Council for Research in Unani Medicine, Delhi, and my RRM Chennai staff for providing me the internet facility and helpful textbooks. Thank you very much. Actually, before going on to discussion or question arises regarding this my study, it's an open assess. Actually, it's a pilot study conducted on minimum patients. I want to propose a new study with to validate this traditional method. So it's an open assess. I would like your valuable suggestion in this regard. What's the basically parameters or biochemical parameters addingly I can add to my proposal. Thank you very much. Yeah, yes sir, no problem. It's a minimal scar, superficial scars which can heal easily. Within 3 days, it's scars disappear of diabetes patient.
Any more questions, please?
Different.
Probably these two, the ingredients which you have used in the formulations contain the flavonoids, probably good antioxidants, which not only bring down, which has a hyperglycemic effect as well as it improves the quality of life of the patient. Right. Right. Thank you. I request Mrs. Irfan Ali to.
Thank you, Dr. Nikhat. Our next presenter is Dr. Irfan Ali Khan from OMICS Publications, India. And the title of his study is Biostatistical Measures and Their Application in Analysis and Interpretation of Scientific Data.
I have decided to talk about the topic. Whatever we are doing, we are not in a position to conclude in such a way where we should show such good results, though the results are good, but our concluding part is not so good. I'm sorry to tell this point, because if we know the ABCD of the subject, we can conclude the subject in a very nice way. So next, see, I'm not going to talk much about the total biostatistics, but the part of it that is measures of central tendency, and in that part, I'll be talking about the mean, the variance, standard deviation, standard error of mean, coefficient of variation, the test of significance, the least significant test, which you can see in only one book described very much in detail, that is about this last test. See, the first part, all of you may be knowing the means x bar, that will be always small x, not capital. If it is capital, it will be indicating the population. We always deal with the samples. So this is small x, sum of x divided by n, then the variance, sum of x, x minus x bar whole square divided by n minus 1 or n. That I'll tell you when I'll be talking about the variance. And the under root of the same, the standard deviation, then the standard error of mean, it's nothing but that is standard deviation divided by under root of n. The coefficient of variation always in percentage, that is standard deviation, that's the ratio of standard deviation and the mean, and that should be always in percentage, but that is a very important part. See, they are the correlating part of the, points about this topic, so I'm not going to talk much about it. You can see there the biostatistics, then the data, that may be the primary data and the secondary data, and the parameter, the variable is the length, and when we talk about the measurement of the length, that we have to see in the plants of the animal, that mean length will be regarded as a parameter. Then the variable that is there, it may be the quantitative, it may be the qualitative variable. The population, all of you know very well. The sample, the size of the sample, that is the most important part when we are proceeding with our studies. We should take care of the sample size. There should be optimum sample size. It should not be the less than 30 or the more than 30. That is not the size of the sample, but the optimum size of the sample where the standard error should be minimized. Otherwise, our results will not be significant results. Clinical trials, all the persons, those who are from any system of the medicine, they know about the clinical trials, single blind, double blind, and the triple blind. Most of the cases, triple blind studies, they are not conducted in India. But if at all they are conducted, I am not aware of the fact. Then the phases of the clinical trials, 0 and all of you know about this because I don't want to waste time here. The measures of central tendency. You see in the case of the measures of central tendency where we have to get the single value. That single value, if you talk in layman terminology as the average. Average is nothing when you take the sum of all the values divided by number of observations will be the average. You see the next, there are two types of the averages, the mathematical and the positional averages. Dispersion. Dispersion may be defined as the measures of variation of the variable. Dispersion is the degree of the variation of the variable about a central value. The measures of dispersion may be range, mean deviation, variance, and standard deviation. The first important part of my talk is the arithmetic mean. You see arithmetic mean is sum of x divided by n. That will give you the meaning of the arithmetic mean. And this arithmetic mean, if you take a simple example, the hospital in Hyderabad where the number of patients they are there, given there the solution part of this problem, the number of observations, they are 100, their total numbers, they are 100 and the observations are 10, automatically the mean will be the 10 only. Now the application part of this part, which is more important here, which I want to discuss more, the oral glucose tolerant test of costus, pictus, leaves, methanolic extract and its fractions. You see the fasting, the 60 minutes, 90 and 120. The groups are normal, metformin, CPME 200 and 500, CP and hexane fraction 200 and 500, CP ethyl acetate fraction that is 200 and 500. That is the paper already published in the Journal Annals of Phytomedicine in 13. See, the most important part of this table is, you see the last line where we are seeing in the 500 case of the last line where all the values are highly significant at 1%, then the next 1%, last value is 5%. So this part showing the values, all the values, they are quite significant. Come to the 200, that is after 60 minutes and 90 minutes. And whereas the hexane fraction is not giving any significant results. And in case of the metformin, all of you know very well that the metformin is a well-known drug where we can get the highly significant values. So the point or the message which is coming out from this table is we should concentrate more on costus pictus ethyl acetate fraction 500, and secondly we can consider 200, and in the same way we can talk about the CPME 500 if we proceed to the further studies on the same aspect. Therefore, I have given the last line, the further studies should be conducted in this direction for valuable findings. The variance, that is the term given by R.A. Fisher in 1913, is nothing but the mean of the squares of the deviations. You see how to calculate the variance. The sample variance, where sum of x minus x bar whole square divided by n, or n minus 1. If you have 30 readings, you less than 30, you use the correction factor n minus 1. If the readings are more, you can go directly to the n, the number of observations. Population mean is there. If you are interested to check your results, where the variance we can calculate with the help of the sigma square sum of x square minus sum of x whole square divided by n, the whole divided by n minus 1. Very simple example of a medicinal plant where the length of the leaves we have considered. The x values are there, the x square values are there. We have taken these values into consideration, the total values. We can see here, after this, putting these values in the formula, we have seen here the variance which is there as 1.59. Quite good value. Now, the application part. Unless and until we talk about the application, this part will not be completed. The mean plus minus standard error of mean, variability and shift in mean for plant yield in M2 generation, where the treatments are controlled, the 20 Kr, 0.2% ethyl methane sulfonate and 0.2% nitrosomethyl urea, where the mean plus minus standard error, the values are there. The S square, the variance is there. Shift in mean values are there. The significance label, after doing this significance label, we got two values. They are significant at 20 Kr of gamma rays and 0.2% of EMS. With these two values, we have to decide which value is more important and how to proceed to the next generation. So based on the 3.38 shift in mean, I have proceeded to the next generation, the M3 generation, for 0.2% ethyl methane sulfonate, but at the same time, I have divided the experiment, control, the random selections, positive selections and negative selections. I got two selections, random and positive, they are giving the significant values, whereas the negative selection is not giving you the significant values. So what we have to do, we have to proceed with a value which is quite important, that is in one message is proceed with the random selection, take one experiment into consideration and proceed with the positive selection, take another experiment into consideration, whichever is good, you can proceed further and get the variety of the mutant. The concluding part I have already given you is standard deviation. This is a part which is given by Carl Pearson, most probably 1893, and this is the square root of the variance. You see the standard deviation, that is nothing, is root of variance, that will give you the standard deviation we have already seen in the case of variance. Now come to the variance, the data I have given you, the example where I have calculated the sum of x minus x bar whole square. The values which I got, I have to apply in the formula and we will get a particular value of the standard deviation. That value will be 8.58. Now the important part is the application. See in the application part, out of this table where the phenolic compounds in methanolic extract and various fractions of methanolic extract of coriander seeds. This paper is accepted in Annals of Phytomedicine, and out of this table, what we got ethyl acetate 7.77 plus minus 0.13 with a standard error of 8.100, and the next is 3.40 plus minus 0.10, and the next value is 1.80 plus minus 0.06. But these values, they are there with the ethyl acetate. Another value which you are seeing in the tannins, that is N-butanol, that is 0.80 plus minus 0.08 with quite good standard deviation. This concluding part is very important here. The ethyl acetate fraction of coriander seeds was found to possess maximum amount total phenolics, flavonoids and flavonols. The above mentioned findings indicate that many of the phytochemicals got extracted in ethyl acetate fraction, and therefore ethyl acetate fraction can be further subjected to subfractionation either using column chromatography or any other suitable analytical technique in order to identify and isolate its active component, which can be further tested for biological activity. If proved effective, then these compounds can be isolated in large quantities and can be used as a source of antioxidant suitable for application in nutritional and pharmaceutical industry or the field. The next is the standard error. The standard error you know very well. It's a very important part. Most of you, I'm sorry, I can tell you my point. If the standard error is more, your values will not be significant. You plan your experiment in such a way where you have to minimize the standard error, get the value significant, otherwise there's no use of your results or your findings. Now, I have given this point, is smaller the standard error, the more representative the sample will be the overall population. The standard error is also inversely proportional to the sample size. If the size of the sample is small, standard error will be more. If the size is more, standard error will be small. So we should take care of this point while we are going to design our experiment. I am going somewhat fast because I have to take care of the time also. Now the maturity data about a variety, that is Aruna. Calculate the standard error of mean. I have given this x minus x bar whole square, and with the help of the variance, then standard deviation, whatever value I got for the standard deviation, that is divided by under root of number of observations, that value is 1.64. This is the way how to calculate. I have to go back. No. Now, the application of effect of semicarpus anacardium linseed extract on ethanolic-induced gastric ulcer in rats. You see, this part of the problem is where we have taken this control omeprazole, very well-known drug, and the SAAE I have already given there, SAEE and SAPE, where the ulcer index, that is 4.00 with the standard error, and these values they indicate, you see the ulcer index in the control, and SAAE 250, that gives the more or less same values. It means this value is not significant. Whereas we are getting the omeprazole and the SAEE, they are the values, 3 values are significant, where the percent protection from ulcer, this is a very important part for my budding scientists, because whenever they are seeing the negative value, they are not taking care of this point. They discard this part of the problem. They proceed with the positive values. So my dear budding scientists, a small advice to you, don't discard this value as far as this is concerned here. You can take one part of the experiment where the percentage protection is 70 in last and 87. You can proceed with this part of the experiment. and negative, that is 8.33, where you have to perform the experiment and you have to see whether this value where we are going to get any recovery index or not. If it is there, that will be a very nice paper for your publication. So this all I have discussed here. Now the coefficient of variation. You know the coefficient of variation. I have already given you the formula. That is nothing. The ratio in between the standard deviation and the mean, and that is always in percentage. So when we talk in percentage, this is inversely proportional. The very simple example, series A, where the standard deviation is given, the mean is given. We have to see the calculation part, where we got the A series 40.46%, next is 29.52%. This shows that the data of series A are more variable, less consistent as compared to the data of series B, which are more consistent. So this is inversely proportional, and we have to see the consistency and the homogeneous nature of the data. Otherwise, the variability will be more. If the data are not homogeneous, when the variability is more, we are not supposed to get good results. Our readings will be not showing any significant results. You can see drug A and drug B. My friend has given this problem because he got some project from Delhi, and I have taken two drugs, A and B, into consideration, whatever he has provided to me, and the calculation part I have already given you. See, mean I have calculated here, standard variance, standard deviation, standard error, and CV. After the calculation of CV, that the coefficient of variation in percentage, you can see first reading is 12.14%, second is 9.22%. You see the concluding part of this, the mean weight reduced by drug A is higher than the drug B. However, the coefficient of variation is also higher for the drug A than the drug B. It clearly indicates that the drug B indigenous is more consistent, more homogeneous than the drug A imported, because the coefficient of variation is less in drug A. We should be very, very careful. This is inversely proportional. The t-test. You know all, so far we have discussed the problems of large samples, whereas the t-test is concerned, this is always depending on a small sample theory. And there are two tests for this. They were given by R. Fisher. R. Fisher in 1926. That test is known as Z-test. Another test is given by William Gossett or William Skelly Gossett in 1908. More than 100 years old discovery with the pseudonym student. That is the t-test. But before I proceed to the calculating part, I'll tell you, my budding scientist, where this pseudonym came from, where he used the term student. Because William Skelly Gossett was working in a brewery in Dublin, Ireland, where he was not permitted to use any name of that factory where he was working. So the top secrecy in the case of the statistical findings in that brewery, he was compelled to use some other term, so he used the pseudonym student. So this pseudonym of the student came from that point of view. So he used the t-test, student t-test. So this is the story of the student t-test. I have given you a very small problem that is given by Dr. Parth Patel, Medicity Hospital, Hyderabad. A sample of 10 adults yielded a mean blood sugar level of 96% mg% with a standard deviation of 9 mg%. Estimate the mean of the blood sugar, glucose level with 90% confidence level. See, this is 90%, 96%. S is equal 9 9 mg percentage, number of observations 10, standard error that is 2.85. Degrees of freedom 10 minus 1, 9. You see the table value in the books, that is T equal at 5%, 9 degrees of freedom 2.26. 96 plus minus 2.85 and 2.26, that will give you the 96 plus minus 6.44 equal 89.56 to 102.44 mg percentage. That should be, that is the, that is about this problem. That will not be common person to person. Paired t-test is there, unpaired t-test is there. This is about the statistical analysis of the t-test. The formula which we got in the last, that is the one value of the t or any two values, that is the mean values difference, then the variance difference, number of the observation, that will give you, the calculation is, when we take 50% subjects as the boys' mean weight and the girls as the mean weight, and we got the calculated value with the help of this formula, where we are getting 5.93. The concluding part of this problem, calculated value is 5.93, tabulated value at 5%, 2.021 degrees of freedom, that is 48, calculated value of T at 5.93, which is bigger than the tabulated value, both at 5%, 2.021, and at 1%, 2.704 labels of probability. The concluding part, there is indeed a significant difference between the means of the two sets of data. This also rejects the null hypothesis that there is no difference of means. The last part of the problem or my talk is LSD test, which is where we have to compare. This is for the comparison purpose, the least significant test, where you can see the LSD test, that is alpha equal T alpha, that is standard error of difference of means. Now the problem, the last problem, in an experiment, fresh weight of the plant was recorded for control and 5 doses of chemical mutagen ethyl methane sulfonate. Calculate the mean fresh weight of the control and 5 doses. The number of observations 120, and I have given you the control 0.1%, 0.2, 0.3, 0.4, and 0.5%. The mean fresh weight in grams and the standard error of mean. Same table, the concluding part. You see after standard error, I have given in the table difference from the control, LSD value at 5% and 1% labels of probability. How to, but the point is important here. We got the value, the first 1.1% is not significant, 0.2% significant, highly significant, 0.3% only significant at 5%, 0.4 significant at highly significant, last value is not significant. In chemical mutagenesis, we should try more to take the lower doses, not the higher doses. So the point where I have given you the calculating part of 10 kr at 5%, the values right side I have given you the calculating part for 1%, and similarly you can calculate for all. But how to conclude your results? You see 3.28 highly significant value. This value is more than the LSD value, calculated LSD value at 5% and 1% labels of significance. That's what it is, a highly significant value. You can see another value 1.29, which is only significant at 5% level of probability. So because this value is more than 1.22 at 5% and not more than 1.6, the one that is at 1%. So we are supposed to be very, very careful while giving this significance label. In some of the cases I have given every value is significant at 1% label of probability. My dear friends, It's not possible. As a biostatistician, I can say it is highly impossible that we can get all the significant values either at 1% or 5% levels of probability. So we should be always careful. While my friends, they are mentioning about the values of significance, they are simply talking about the concluding part of the problem, that I got the significant results. We are not supporting the documentary or any statistical evidence. So my dear friends, you should be very, very careful while writing or using the word statistically significance. If it is significance, you please prove it. If it is not, don't talk in your concluding part. That will give you a wrong message, negative message. So the next point is, Rao sir, I have given here one Einstein quotation. Try not to become a man of success, but a man of value. This is, the last is, thank you for hearing me out.
Thank you very much, Dr. Irfan Saab. Probably we'll take the next speaker. We'll skip the question part. Next speaker, please. Request Dr. V.C. Gupta to...
Thank you, Dr. Khan. Yes, next is Dr. V.C. Gupta, Department of Ayush, India. Please welcome Dr. V.C. Gupta, Department of Ayush, India.
Respected Chairman, dignitaries and dear friends. Today I got the privilege for presenting my paper on agrotechniques for the conservation of genetic diversity with special reference to Unani medicinal plants. Actually, I have done this work in Central Research Institute for Unani Medicines, where I worked for near about 33 years. And this, as we know, there is a lot of demand of medicinal plants nowadays. But at the same time, what we are observing that most of the important medicinal plants are also disappearing from the natural resources. What is the reason? As we, maybe the biotic factors, maybe the forest fires, grazing, or illicit removal of the medicinal plants from the forest areas because of its more use. But our aim is to protect the medicinal plants. How we can protect? So for that purpose, we have chosen some agrotechniques for the cultivation of medicinal plants for their regular supply. Next. As a positive step in the institute, what we have done, we started to initiate the collection of germplasm from the forest resources so that we can transplant those germplasm in our medicinal plant garden. And we succeed a lot for that purpose. We have transplanted most of the important medicinal plants, and then we taken into the consideration regarding temperature, climate, etc., and the environment. In the introduction, I have shown that the forest areas from where we have collected, they have the latitude and longitude of the area of Andhra Pradesh forests, which are generally in the Dakhan tropical and Gondwana formations. And then this is the literature from Joshi, Shilendra, and Safiuddin. Next. The forest and its vegetation, most of the forests of Andhra Pradesh are next to Madhya Pradesh, Odisha and Maharashtra. And the most of the forests of Andhra Pradesh are deciduous. And mangrove forests are in the mouth of river Krishna and Godavari. Red sandal is present in Chittoor forest and Kadpa forest areas, and bamboos are common in the Adilabad, Khammam and Srikakulam. In results, what we have done in our work, that I want to tell you that we have selected some 52 plants for the conservation of medicinal plants, which are very important from the Unani point of view. And for that, which plants we transplanted in our herbal garden, we have seen which are the proper places for those plants. For example, Edatoda gelanica, this can be grown in the marginal hedges. Aristolochia indica, that can be grown in the shady places. In Asparagus racemosus, that can be grown in deciduous forests of Andhra Pradesh. Acacia angustifolia, Sanna, can be cultivated in the herbal gardens. Next. Clariodendron as a hedge plant in the herbal gardens. Commiphora viti, that can be grown as a deciduous forest areas. And tree plants like Terminalia arjuna, Terminalia bellerica, Strychnus potatorum, these can be grown as a plants on the towards both sides of the roadsides, can be grown as avenue trees. In addition, some of the plants which don't grow in the forest can be cultivated in the herbal garden, like Revolfia serpentina, Andrographis paniculata, and Seraca indica. For this program, it is very important to have the combined approach of medico-botanists, forest officers, agriculturists, pharmaceutical personnel, so that we can make this program as a success, and where the cooperation of the government is also very necessary. And we have to see the infrastructure operating, such as drying, packing under hygienic conditions, because dry shade plants is very important. Otherwise, we will lose the chemical constituents percentage also. In this agro-technique program, what is our aim? Our aim is to create awareness about the value of medicinal plants, to improve the good agricultural and collection practices, to improve the quality and quantity of the drugs, to create awareness about the latest technology and marketing information. Next. In agro-techniques, what we have chosen? We have chosen the propagation, type of propagation, type of soil, harvesting period, space from plant to plant, manure and their yield. In propagation, we have seen, for example, Acacia angustifolia, that seeds are important. How many seeds? 5 kg per hectare may be required. In that can be grown in all type of soils, and harvesting can be done in 90 days. Space 40 to 30 centimeters, and the manures in farmyard manure can be used as a 5 to 10 tons per hectare. Nitrogen can be 40 kg per hectare. Then potassium and zinc sulfate are in the equal proportions. And the yield can be obtained 2000 kg dried leaves and 800 to 1000 kg pods per hectare per year can be obtained. Similarly, with these techniques, like be followed for Withenia somnifera, ashwagandha, aloe vera, ghee guar, Catharanthus roseus, Acorus calamus, Glycyrrhiza glabra. In Glycyrrhiza glabra mullathi, we use root cuttings and the wide variety of soils. And the harvesting is done 15 to 24 months after planting. And the space is 5 into 45 into 60 centimeter. And the manure, farmyard manure 15 to 20 tons per hectare, nitrogen 40 kg, potassium 20 kg, zinc sulfate 25 kg per hectare. And the yield is 2 to 3 tons of the dried roots. Similar processes are done for the Piper longum, Revolfia serpentina, Gloriosa superba, and Vetiver gigionioides. Next. Rose marinus. It is an insect repellent plant, and stem cuttings are used for its propagation. Light loamy soil is used. Harvesting is 8 months after planting. And like that, spacement and manures and yield is 12 to 15 tons of the herb per hectare. And similar, the plants which we used are Coleus farsiculi. It is a very important plant. Mucuna pruriens, it is aphrodisiac. Andrographis paniculata is used, and Ocimum sanctum. These are used in the acro techniques with the very good turnover of the yield. Now, what we have seen that there is an important program should be done to conserve the indigenous medicinal plants. How we can done it? Afforestation is very important for the important Unani medicinal plants so that we can conserve those plants. In agrotechniques, other factors are also important to conserve the plants. How? Collection of the plants is very important. And the proper way is when we conserve the plant, when we collect the plants, our suggestion is that these plants should be collected by the cooperatives of the Adivasis, because these people who live in the forest, these can be, that is very beneficial for us. And these persons should be trained how to collect the plant, what to collect, and where to collect, and the timing period of the collection, because these are very important. Timing of the collection is very important, otherwise we will lose the chemical constituents. Then second point is we should develop the drug depots also in the forest areas, because if we will make some drug depots, those should be hygienic. Those depots should have the drying and storage facility. Shade drying is very important for the dry of the crude drugs, because we can protect the chemical constituents of the medicinal plants. Percentage will be more. And there should be a link between the collecting person and the buyer. There should be a very good linkage. Next. In addition to this, we should also develop near about 100 modernized drug farms for ISM in the forest research stations. Because these modernized drug farms are very important. Because in those modernized drug farms, we can keep small nurseries also, where we can protect the germplasm, we can collect the germplasm for the farmers, for multiplication. And where we can use these nurseries with the scientifically, with the help of our scientists or forest research stations, where we can use expertise persons from the agriculture universities, from the agriculture department, where we can use tissue culture techniques for the multiplication of the medicinal plants. And so that we can develop a strategy for some of the important Unani medicinal plants. In this work, we are really thankful our Director, Central Council for Research in Unani Medicines, and also the DFOs of Narsapur, Vikharabad and Adilabad Forest, from whom we have taken the help for this work. These are the references which I have consulted. I will show you some of the slides also, which plants we have taken for conservation, and with their medicinal value and chemical constituents. In Unani, this is a Tephrosia purpurea, which is called Serpuka, blood purifier. Tephrocin and isofrocin is the chemical constituents. Dragia volubilis, nak chikni, it is used for cold and eye disease. Glucoside and draginia are the chemical constituents. Acacia consina, shikakai, here shampoo is used. Saponin and alkaloids are present. Jasminum, grandiflorum, chameli, it cures ulceration. Salicylic acid is present. Then Astracantha longifolia, it is a diuretic plant. Talmakhana, seeds are used, and phytosterol and semi-drying oils are present. Argyria speciosa, samundar sok, it is used for as a rheumatism and nervous disorders. Fatty oils are present. Then Artemisia nilgarica, Nagdona, anthelmintic, glucosides and absinthin are present. Withania somnifera, ashwagandha. It is a general tonic and presence of alkaloids. Citrus medica, turanj, anthelmintic and tonic, limonene and citral are present. Turbut, operculina terpithum. Roots are purgative, glucoside and terpentine are the chemical constituents. This is Revolvia tetraphylla, another species. Reduces blood pressure. In our Unani system, Revolvia serpentina is very popular and that is used. Revolvicin and aspirin are the chemical constituents. Sonjana, Moringa oleifera. The roots are epilepsy, for use for epilepsy. And the chemical constituents are oil from the seed contain moringin. Rajinigandha, Polyanthus tuberosa. Flowers are diuretic and essential oils are present. Mucuna, pruriens, conch. Seeds are aphrodisiac and it is a very important plant nowadays. Seeds are also exported to other countries. Alkaloids, mucinin and mucodine are present. Mucilicea, Curculigo arcoides. It is a general tonic and diuretic. Gloriosa superba. It is a very, very important plant. Now it is a rare also. Roots are purgative and leprosy. We are thinking for how to conserve this plant. Alkaloids are gloricin and colchicine are present. Piper nigrum, Philphilacea. Stimulant and sore throats are used. Alkaloid piperine and piperidine are present. Gymnema sylvestris, Goodmar. It is used as a hypoglycemic. Gymnic acid is present. Coleus ammonicus, Patharchur. It is a carminative plant. Essential oils and carvicrol are the chemical constituents. Xanthium stromborium, Gokhru. It is a diuretic and sedative. Glucosides and xanthostromborium are the chemical constituents. Artemisia absinthium, absinthin. It is anthelmintic and used as a chronic fever. Glucoside absinthin is present. We are trying to conserve all these plants and we have cultivated in our mini herbal garden in the Central Research Institute for Unani Medicine. This is a Rosmarinus officinalis. It is an insect repellent plant. Carminative and stimulant, essential oils are present. Stachyphyta indica. It is used as intestinal worms and ulcers and the glucosides are present. Cassia alata, skin disease and chrysophenic acids are present. Cassia angustifolia, purgative, and cinosides A and B are present. Hibiscus cannabinus, seeds aphrodisiac and the chemical constituents are cannabicentrine. Bacopa monellari, it is a Brahmi. Centella asiatica is also a Brahmi. And in Ayurveda, it is the Bacopa monellari is used. In Unani, we are using Centella asiatica. Chemical constituents, both are having the same as a brain, and the use is same as a brain tonic. Brahmin is the chemical constituent. Sisimum indicum, Kunjat, arthritis and diuretic, we are using its seeds. And Nasidine are the chemical constituents. Vitex nigundu, Shambalu. It is used for arthritis. Essential oils are present. This is Plumbago indica. It is a very rare plant. And it is present in the Rajmandri forest. Paralytic affections and cytosterol are the chemical constituents. Sterculia urens. It is a Kathira. Gum is used. Stomachic. And gum is a substitute for tragacanth. Butium anosperma, gulatisu. It is used for jaundice. Glucoside, butyrine and butene are present. Sraka indica, Ashoka. It is used for thinning the blood. The bark is having tannin and catechol. Costus speciosa. It is a very rare plant. Pushkar mood. Most of the roots are used for export purpose. Roots are used as a bitter and purgative. Starch is the chemical constituent. Ruta graveolens, Sudab, for cough and cold. Glucoside, rutin and essential oils are present. Abrus precatorius. It is used, the seeds are used in family planning. Abrin, glucoside are the chemical constituent. Psychorin intibus. It is used for jaundice. glucoside, cyclorin, and intibin are the chemical constituents. Habul khilkhil, cardiospermum helicacavum. It is used for rheumatism. Saponin are the chemical constituents. Commiphora mucal, Google. It is used for rheumatic arthritis. Gum, resin, and essential oils. So these are the plants which we taken into consideration for conservation of the medicinal plants in CRI Hyderabad. Thank you, sir.
Thank you, Dr. Gupta ji. Probably I request Mr. Dr. Sharik Zafar to compliment Dr. Gupta ji with this.
Thank you, Dr. Gupta. I would now like to invite Dr. Anil K Mandal of Mandal Diabetes Research Foundation, USA, to present on the topic glycemic control with intensive insulin treatment, fundamental to renal preservation in diabetes.
Thank you very much. I want to tell you that, sorry about that. I want to tell you when it comes to catching flight, I feel a little bit impatient as well as a little bit nervous, even though I have traveled around the world. You know, I'm a million-miler of Delta Airline. Still, when it comes to fly, I'd be rather sitting 2 hours in the airport and not miss flight. So bear with me. I may not be as jubilant as I was on the first day because of my impatience and little nervousness, but I shall try my best. In the previous speaker I heard about metformin, and I shall show you how spurious this drug is. It is merely to help pharmaceutical company deliver the product into the patient, so the doctor acts as a vehicle to deliver the product from the pharmaceutical industry to the patient. It does not do anything in diabetes. It lowers the fasting glucose, lowers the hemoglobin A1C. I have shown the data on Monday, but not 2-hour postprandial glucose. In diabetes, 2-hour postprandial glucose or glucose tolerance test to show the 2-hour postprandial glycemia, or by standard breakfast or lunch, 2-hour glucose level is the crux and relate to all the complication of diabetes. So our focus would be to prevent complication and not to help please the pharmaceutical company. Here is this presentation is intended to reveal gaps in knowledge in fundamentals of diabetes care, probing 2-hour postprandial hyperglycemia essential to prevent complication, and consideration of alternative medicine to treat diabetes. I was told by Mujib that whether if I can present few slides, so I reviewed the literature. I have no knowledge of alternative medicine, but I reviewed some good literature provided to me by my librarian, and so I show you few slides on that. But fundamentals of diabetes. Incidence of diabetes mellitus is increasing due to population aging and urbanization, which include overeating, which is true. Better economic condition. Prior to World War II, their economic condition was very poor, including in India. There was, after the British left, there is a widespread famine, no food at all, and many countries about the same. But now, at least a better condition, people eat more than they did prior to World War II. Diabetes is not epidemic. That's a fallacious. I shall show you why diabetes is not epidemic. It's due to faulty diagnosis. Take a look at You only use fasting glucose or hemoglobin A1C. That's it, to make a diagnosis. But that's not the real diagnosis of diabetes. Diagnosis of diabetes has to be made on the basis of 2-hour postprandial glucose. Now, you must know that more people in the world have hypertension than diabetes, right? And most common drug used to treat hypertension or lower blood pressure is hydrochlorothiazide or thiazide diuretic, either hydrochlorothiazide or chlorthalidone. That's the drug was started to lower the blood pressure. And what does that drug do to you? Unawareness of 2-hour postprandial. Even my senior colleague, nephrologist, I met him in Seattle in the dialysis meeting, and I asked him how often does he order 2-hour postprandial glucose. He said never. He does not know even. My senior colleague, nephrology in US. Little attention to review of medication which may be diabetogenic, like transplant patient get tacrolimus, very diabetogenic. Steroids, often patients get for arthritis, for dermatitis, and you name that how diabetogenic those drugs are. Result is fallacious overestimation of diabetes. Take a look at this patient. I cannot emphasize to you anymore. Patient diagnosed hypertension, and I was a director of that hypertension clinic in Wright State University, Dayton, Ohio. 1993, he was getting trimethylene hydrochlorothiazide, as I mentioned, most common drug used to treat hypertension. He came in July 7, fasting glucose 200 milligram. The nurse practitioner told, you have developed type 2. Type 2. There's such a bogus term, type 2 diabetes. But she called me also. So I said, okay, I'm coming to see the patient. What did I do? I stopped that medicine, I continued with the felodipine because his blood pressure was under good control, and asked him to come back 2 weeks later with another basic metabolic panel. And take a look at 2 weeks later, his fasting glucose was 105. Now, why is that difference? Take a look at the BUN serum creatinine. So I use the word basic metabolic panel, which provide you glucose, BUN, creatinine, and electrolyte, right? Okay, so look at his BUN creatinine were elevated, his urinary electrolyte, sodium was low because dehydration. Now, after 2 weeks, he became repleted of fluid. So his glucose dropped, his BUN dropped, serum creatinine dropped, and the evidence that he was a volume depleted, his urinary sodium increased from 37 to 86. Be thoughtful, be assertive. Don't think what other people telling you to do. So his diagnosis is hyperglycemia induced by volume depletion from hydrochlorothiazide, no diabetes. Now, would I be not in the picture, the nurse practitioner was going to start him on metformin, and he will continue that. Trimethylene hydrochlorothiazide and trimethylene. And another doctor will come, continue that. And that's how epidemic of diabetes. Another patient, take a look at. The patient, I continue to follow this patient. September 8, 2011, she was getting diazide, which is a hydrochlorothiazide trimethylene brand name, Mondays and Fridays, and amlodipine, control of blood pressure, and potassium chloride. You see that 2-hour postprandial glucose 207, and was told by the primary doctor that you have developed diabetes. All right? So he came to me, and I hold diazide. I decreased the potassium because the renal function decreased slightly. Then I asked her to come back with another lab called fasting basic metabolic panel and 2-hour basic metabolic panel. That's my typical prescription. Take a look at glucose drop, renal function, serum creatinine decrease, eGFR increase, potassium remain unchanged. But she always liked diuretic. So I discontinued diuretic for some reason. Hydrochlorothiazide or thiazide diuretic increases glucose much more than loop diuretic such as Bumix or furosemide, all these other diuretic. So she'll always like to take some diuretic. So I put her on Bumix, and Monday, Wednesday, Friday increase her potassium because hypokalemia is a major cause of hyperglycemia induced by diuretic. We do not know the pathogenic mechanism, though, quite well. Now, take a look at November 2011. Glucose levels are normal, kidney function stable, and potassium stable. 64-year African-American male referred to me for uncontrolled hypertension, hypokalemia, medication, diltiazem, amlodipine, and trimethoprim hydrochlorothiazide, 25 milligram once, 37.5 over 25 daily. Potassium 3 times a day. Now, follow the year 2009, 2010, 2011. Random glucose 186, first visit. Of course, that is elevated, like a diabetes. Anybody will tell, oh, you have developed type 2 diabetes. What a big job they do. I discontinued trimethoprim hydrochlorothiazide. Look at that. 2 weeks later, fasting glucose was normal. 2-hour postprandial, slightly elevated. Hemoglobin A1C, normal. December 30th, 2-hour random is good. Hemoglobin A1C even further lower. 2010, July 1, fasting glucose normal, 2-hour postprandial lower than fasting. And 2011, 2-hour postprandial lower than should be. So what that mean? High insulin response. So I order insulin. Look at insulin at the bottom, 62.7. So I told the patient that he has a high insulin response. And the next graph will tell you. Here is a study done a long time ago that a fasting glucose with a challenge oral glucose tolerance. At the top of the graph, that's the highest insulin response, and directly below is the fasting glucose 120. That's typically seen and in patients who may become diabetic. Why? Because when you see this, oh, you have insulin resistance, very high. You take metformin and you give the metformin, this insulin response over time will drop and will become overt diabetes later on. So what should you do? High insulin response, diet control. Ask them small frequent meal, not a big carbohydrate meal, so that insulin response subside. Be proactive and thoughtful at all time. So that's what it shows on your left-hand side. So the diagnosis of diabetes, according to World Health Organization, venous plasma glucose concentration of greater than 200 or greater than 11.1 millimole per liter, 2 hours after a 75 gram glucose tolerance test. Now, that is a little cumbersome test to do because patient has to wait in the lab 4 hours. The laboratory personnel don't like patient waiting in the lab for 4 hours.
Allopathic product, which means you have to have clinical studies to establish that this product is actually has clinical efficacy At the same time, you have to establish that there is a good facility which is controlled by the good manufacturing practices, which is taking care of producing a viable product for use by the common people. At the same time, to ensure that good quality pharmacovigilance is there and the inspection system is there to curb any menace if it takes place in between. So the regulations are there, NHP regulations, which are parallel to the allopathic drug regulations. After Canada introduced, European Union followed suit. Once European Union followed suit, United States very, very slow, where they still treated natural health products as food supplements. And now finally, they have come up with a set of regulations for the natural health products themselves. So the market for India and China, there is a domestic market, but that is cents market. If they go to the United States, Canada, or Europe, it's a dollar and pound and euro market. What you sell for 1 paisa here, the same substance you can sell over there for $10. In '96, when I came here in this city with the second conference of the Drug Information Association, that was in Sheraton Grand Kakatiya, I made a point to the gathering of around 500 people. I said, what you're producing here is dirt cheap. I gave them an example. I said, what is the cost of antacid, the Glaxo antacid, what is the name of the drug? Zantac. Zantac, very common drug. So I said, how much does it cost? Somebody in the audience replied, it costs 8 rupees for a strip of 10 tablets. I said, you know what is the cost in Canada? It is $85 for 60 tablets. On top of that, I have to pay $15 as the dispensing fee. And I'm happy to buy it because I earn in dollars, I spend in dollars. So that clicked. And the industry here started acting. I said, the prerequisite is that you have facilities which could meet GMP standards. Invite for inspection. Once your facility passes the inspection, then you apply for the drug application for approval of the drugs in the United States, in Canada. And in a couple of years' time, 80 pharmaceutical establishments of Indian origin were already approved by the United States, which set a record. No other country in the world, except for the United States itself, had 80 pharmaceutical establishments approved. India became #1, and today India has almost around 150 to 160 establishments which are approved by the United States. Lupin Pharmaceuticals, I was looking at the IMS data, 2012 sales ended with $3 billion, which was the total sales of the Indian pharmaceutical industry when I made the remark to the industry here. So the NHP sales market is United States, Canada, Europe. That's where the money is. If you don't follow the regulations, you have no access. The government of Canada was very generous. They said the products which are already on the market, they will not require any submission, but they will have to obtain a natural health product number, which goes on the product label, NHP number. Allopathic products have a DIN number, DIN, drug identification number.
Excuse me, Dr. Khan, for intervening. I never said that we don't need regulations. The very purpose of the title was overly regulated. Why? Environmental Protection Act will come into play when your particular plants are working. The first thing they do was control alternative medicine, this plantation, by bringing in regulations of environmental protection. Okay? Biodiversity is brought in to see that when certain components from animal origin working, See, there are nexus as a term. No, I'm not saying that regulations are not, should not be there. I'm saying overly regulated and taking opportunity of these regulations. The hidden hand is the main industry is playing its game. That's why we are like this. Let me tell you, we brought in an Indian village scenario. I was 20 years a drug regulator officer. I used to visit the clinic. There are 3 physicians. One is suit with a tie like me, other guy with a dhoti, other guy with a small pandit. He's an Ayurvedic pandit with a small tail. Nobody goes to the Ayurvedic pandit with a tail. Okay? They never approach the homeopathic because that fellow prescription hardly costs 25 NP. The guy with the suit, he gives injections. Sudhi, that is a perception of the villagers. Unless you are injected, medicine is not given.
Placebo effect.
So the villagers' perception of alternative medicine is as good as you may blame these urban people. But let me tell you, sir, British, first I'm not saying by anybody from British, and I have no hatred. I'm an American citizen. But I want to say one thing. The first decree the Viceroy brought at Calcutta was to close the Ayurvedic college. With one stroke, they closed the Ayurvedic college, where Ayurvedic system was taught. When did we revise it? We got independence in 47. But even then, did we progress? I don't think so. It is the attitude of our own people. We are not the leaders. We are not the Indian Ayurvedic system or Indian, though we are very, very, 5,000 years back, we may proud and beat our chest, but we are not doing as much as needed. We have fallen into the hands of the regulations of the environmental control and biodiversity protectives. That message I want to give, that unknowingly we are falling into the trap of this overly regulation. Hidden hand is somewhere else. There is a nexus between these three, as I call them as Almighty, as the Trinity, industry, government, and as well as academia, with a falsified documentation of the results. I think you want to say.
I'll just make a brief comment. If there are products with Ayurvedic products with heavy metals, they will not get entry into United States, Canada, or Europe anymore. That is gone. So a big chunk of the Ayurvedic drug market that will not be able to flourish in those countries. In the country here, if you see strong logic behind carrying the heavy metals, it is up to you. So you can have double standard. You can have factories catering to the need of the Indian population based on likes and dislikes of the Indian practitioners in those fields. You can have another set of factories for export purpose only, which are inspected by the inspectors from Canada, United States, and Europe, who will come and approve the facility and the systems, and then allow the entry of the drug into those markets. So you can make money that way too. But playing double standards, it doesn't serve the purpose, because China has been playing double standard. They have fully regulated export business, but the old Chinese people who are living for example, in San Francisco or Vancouver in Canada, now Toronto City, which is almost half the city, has gone Chinese. The old generation of Chinese who are living there, they still want to see and use the products which are originally they were using when they were in China. So for them, the products somehow are finding the way into the market, and when side effects are taking place, the health ministry is taking note of it, and they are issuing warning letters to the Chinese manufacturers. So this will happen. Now,
I would just completely buy what Madam said, and also Dr. Pipala said, Dr. Khan also said. Regulations, yes, I also earlier said that regulations are required and they're a must, but at the same time, they have to be in a broad range. And probably this gap that we are discussing as of now, and we keep discussing at every other moment, be it a forum, be it our individual discussions, this can only be bridged across when we have proper education, when we have these systems of medicines evolving into an education pattern, into an education form, where we can convey what we want to say to the other person. It's like I talk, say, Spanish and you talk English, and you do not know Spanish and I do not know English. So it's more like we have to bridge that gap of those different forms of knowledge of the same thing, because end of the day, any of these systems is treating the same human being. The body remains the same, the systems remain the same, the mechanisms remain the same, except for the description of it. So it has to do with the education part, and the day we have the right education formats in place, probably the regulation part will automatically take a backseat, and we may not be discussing it in the wrong set of contexts, but probably in the right set of contexts.
Let me answer Dr. Khan's point about the heavy metals. The article is well published, and it is on the website of FDA, right? But Nagarjuna, the first alchemist of the world, he taught his disciples the usefulness of the metals. Bhasmam. It's a nanoparticle. You give a fashionable name to Bhasmam, call it as a nanoparticles. A group of nanoparticles is Bhasmam. Okay? Nagarjuna found some use of these metals. So I don't go into the war-blown, the heavy metals found in the Indian system, they should be banned. No, you have a point, because to enter into the market of USA, we have to clarify to the FDA, it is our own system of medicine. Why heavy metals were present, what to be present, they are aware. So let us, I don't delve into that, because there are some useful Ayurvedic experts can explain why Nagarjuna brought this Bhasmam into this, our Ayurvedic pharmacopoeia. He can explain, because he is the first alchemist.
I could give an answer to that. The benefits of the heavy metals is not debatable at all. The previous books, the text of medicine in Western world, it has documented and it has been using heavy metals until the time when they realize that the benefits, the risks from the use of heavy metals outweighs the benefits. I gave an example during my opening speech that antimony, it was extensively used in Europe by the doctors until such time in the 15th century when the College of Physicians of Paris, they found that it was too toxic, although it was beneficial, but it was too toxic at the same time. So they banned the drug from being used by any physician at all. In the 17th century, in the 16th century, King Louis XIV, he got ill. So the royal physicians were attending him, giving all kinds of allopathic medications. Nothing happened. Then a quack said, I want to treat him. He treated. He gave antimony, and the king became okay. And for the next 200 years, antimony was again on the European market when it was finally banned. So what I am trying to say is, why did antimony prove beneficial to the king? Why not to another person? The human physiology is different from person to person. One has a greater level of tolerance, other doesn't have. But in the vast majority of the cases, I made a point here that because of lack of pharmacovigilance, we don't know what is happening to those poor people in the villages who are being served with Ayurvedic medicine containing the heavy metals. There is no pharmacovigilance. If we do a study, proper scientific study, if we still find that it is beneficial without producing toxicity, without producing mortality, then there is a point to come up and prove to the Western world, this is our documentary study, you take care of it now. That has not happened. So I don't dispute the benefits of the heavy metals. I mean, silver and gold, the leaves were applied on the sweetmeats, mithaiyan jo bikti thi yahan. Common man, he always purchases it with a silver leaf on it. And the more rich, they purchase it with the gold leaf on it. So they were eating the gold and silver with the sweetmeats. That was a tradition of this city when I was young. Exactly. They do it. They do it. So I'm not disputing anything which is being practiced here. I support it because it is serving some purpose. If allopathic medicine is not available to the poor villagers, at least Ayurvedic is there at a lower cost and they are getting benefit out of it. But we don't know how many are suffering from the serious side effects, how many are suffering from the toxicity, how many are losing their lives. There is no count of it. There is no surveillance of it. That is the sad part.
Yes. I just want to add a few comments. First of all, in the United States, we have a number of universities which teach Ayurveda. University of Minnesota is having Ayurveda classes for over 15 years. And we bring students to Rishikesh and wherever it is to give them exposure. When it comes to yoga, we have been teaching it for over 50 years. From the time Swami Rama came to Minnesota, we have been teaching yoga. In fact, one of the courses in USA which provides teaching certificates in yoga is in Minnesota. So we cannot just say that all negative about what is happening in other countries. You go to Germany, you go to England, number of Ayurvedic practitioners are there. So what we want to do is just some positive suggestions. One of these is, if Ayush, the administrative body of all of these, is strong enough, they should standardize first. If we are proud of it, they should promote it first, not lay back. In India abroad, 3 months ago, Nirupama Rao said that Ayush has issued this mandate that all their Ayush products will be clinically tested. I have not heard a thing so far. So we have to look at our own regulation first. Let us standardize our products here.
Great.
First.
Great. Let me address this. First of all, respect your profession. I respect the colleague. I invite all the alternative experts sitting here. Respect yourself. Many are so apologetic. I don't have enough number. No. Each patient is a subject. There is a science called narrative medicine. I'm promoting in my own way narrative pharmacy. Each patient history is very important. Narrative medicine is nothing but marriage between the literature and the medicine. Patient is important, single patient. Follow the patient wherever he goes. Cardiology today, internal medicine, nephrology, cancer. Follow the patient. Routine, the internships are now given. Because I'm addressing Dr. Rao's useful suggestion, let us take grants, money available from the Ayush. Because don't be apologetic, because you should have 100 patients. No. Nowhere it is said. It is their standard of allopathic medicine. Numbers to treat, to estimate, power of the study, on 1 minus beta, alpha, type 1 error, type 2. Don't be scared. That do not apply to alternative medicine. Each patient's story is important. Anecdotal evidence record. Be confident. Write grants. Because somehow most of you are so apologetic. No, I could not get more than 10 patients. No, 2 patients are sufficient to make a scientific point, scientific history. Okay? Don't be apologetic. Take the opportunity of Ayush. Take the opportunity right, and outcomes are very important. It is the patient's, these are the days of the patient outcomes. It is he who decides which medicine is good. The physicians are no more gatekeepers, at least in India. It is the patient who is the gatekeeping your medicine. If he is okay, physically, mentally, socially, their outcomes, you measure it, write grants. And especially alternative, my purpose of my presentation in the first day also like that. Please measure the outcomes, how patient feels, write grants. Okay, I think we are running out of, I'm so sorry.
Can I make a final comment?
Sir, from the discussion, the message is clear. So we should work very smart. The days of working very hard is over. We should able to work very smart and to get these regulations in our favor, and we should able to globalize the traditional system of medicine, especially Ayurveda. And what Dr. Rao told, depending on Ayush is very difficult, because Ayush is not having the leadership to take Ayurveda in a global scale. Because they're, as you rightly told, they are suffering from their own image crisis is there. Because they themselves feel that they are a step below. Then you cannot take it in a global level.
Spirituality is a unit in Boston, a school where they teach spirituality. Prayers are introduced into the discipline of the medicine. Prayers are introduced in the discipline of medicine, not in India. There in USA. Spirituality domain is going to be added to the health definition. The spiritual dimension is great for the traditional medicalists. Write some grants, because spirituality has its own impact. That is in Boston. There is an institute called the Outcomes Institute. They teach about the spirituality also. But the only thing is, within us, our self-confidence levels are very low, sometimes to the extent of self-abusive. Why you do so? You are great in your own profession. Your one patient is great for your research. Please. That feeling should be there.
Let me make a final comment. Regulations, they are not to be afraid of. It's not a problematic situation. Regulations are simply meant to ensure that the facilities which are producing the drug products, they are clean and sanitized. It is to ensure that the machinery which is being used to produce the tablets or capsules are clean and sanitized, and also to ensure that no cross-contamination takes place, that they produce one drug product and without cleaning they start producing another drug product. Then the residues are being passed from one product to another product, causing sometimes detrimental effects to the end user. The regulations are meant to ensure that the workers in the facility, they are well trained and they have good hygienic qualities, and that they pursue the procedures, manufacturing procedures, or quality control procedures based on the document which has been produced by the organization itself for the benefit of all. It is also, regulations are also to ensure, as he pointed out just now, that the drug products which are being produced and the raw material which is being used is all standardized. If the formula is requiring 90 to 100% strength of the active raw material, it should be between 90 and 100% when it is being used for the manufacturing of the product. Now, somebody in the earlier presentation made a mention of bitter melon for the treatment as one of the options of treatment of diabetes. There is a research going on in Canada at the University of Toronto at the St. Michael Hospital, which is exploring the usage of bitter melon for the treatment of diabetes. And using the bitter melon, which is available in Canada, they found that it really works. So they had a control study, and they found it works. The person who was doing the research is an Indian fellow, along with other Canadian doctors. So on holidays, he came back to his hometown, Lucknow. He thought, let me ensure that the bitter melon here is also of the same quality. So he prepared the required medication, and he gave to a set of patients in the Lucknow. It didn't work that well. Why? because the soil here is different and the soil there is different. That soil is providing some extra ingredients to the bitter melon which the soil here is not providing. So agricultural practices, those will have to be controlled. That's part of the regulations, that you follow suit based on specificity of the quality of soil and protect the plants from any noxious sprays, that you let them grow organically. So those are the requirements. So it's not a big issue. It's simply controlling what you are doing already. Now it is being done haphazardly. When you take, as I pointed out in my presentation earlier, when they tested ginseng, they found 80 times variability.
I'm sorry, Dr. Khan, to interrupt. I'm impolite a little bit because they're all with the sleepy eyes. Everyone is cursing, but the cursing, I could see there. The curse, the eyes are very powerful, especially the women sitting here who are working. They're signaling with their eyes, shut up and go.
Well, they are all free to walk out if they wanted to, but the fact they are sitting here is that they are finding some meat in the substance. You know.
Finally, we thank to the OMICS Group who has done a remarkable work. The whole team has done a remarkable work for conducting the conference. And it was the initiation for the promotion of traditional system of medicine. In the future, we will also conduct some conferences in the future, and accordingly the scientific publications from all around the world will be published in the OMICS journals. But one request is that at least as far as the payment for the publication is concerned, it should be freely published from at least from the Indian subcontinent, because that is a major problem of publication. Our researchers are not going globally due to this drawback. They have to pay $1,000 or $2,000 for one publication. That is unaffordable for the Indian researcher. So that is my request, that at least these researches, so that they can go globally.
As a basic scientist who doesn't belong to any therapeutic profession, I thank the OMICS Group for inviting me. My contribution is just some positive suggestions for all of you from the point of view of science and globalizing our traditional medicine. Thank you very much.
Sir, I would like to answer you regarding the publication fees. Keeping in your point in mind, OMICS Group has even started subscription-based journals which do not charge any publication fees from the authors. And the name of the journals, they are named in the group called ChAttopadhyay, and we have 50 journals in that subscription-based journal. So you can access, I mean, if you are not willing to publish in open access and do not want to pay the fees, you can publish it in the subscription-based journals. You can find the relevant journals and you can submit your manuscripts in them. Thank you.
Just to let you know, 4 months ago, 2 products, new herbal products, those have been officially approved by the US Food and Drug Administration, and they will be used by the allopathic practitioners. Those are supportive medication for the AIDS patient, AID patients, you know. But 2 new products have come on the market with proper submission.
As this conference is in India, so we have to sum up this with Jana Gana Mana. Okay?
Jana Gana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravid Utkal Banga Vindhya Himachal Yamuna Ganga Uchchal Jaladi Taranga Tab Shubh Naame Jage Tab Shubh Ashish Mange Gaye Tab Jaya Gatha Jana Jana Mangal Dayak Jaya He Bharat Bhagya Vidhata